Okay, so welcome everyone to the 34th lecture of Dr. Hyderi Step 1. First and foremost, happy Thanksgiving to everyone and hope you guys are having a great day. Thank you so much for all the wishes and hope everything is going well with you guys. How is everyone doing? How are you guys? Are you guys doing good? Can you guys hear my voice? Is everything clear? Okay, you're welcome. Do I have a clear voice? Can you guys hear my voice? Okay, perfect. Perfect. With that being said, once again, thank you so much for attending the lecture on a holiday. I'm not sure how much of Thanksgiving is being celebrated in your respective countries, um, but over here it's a full-fledged holiday, and I really appreciate you guys putting in the time for being here. Um, First and foremost, uh, it's about time that I asked you guys how many questions you guys solved yesterday regarding your psychiatry questions and how were those questions. And the second, then number two is how many questions did you guys find in psychiatry that were common to our lectures? Yes, of course, Dr. Hussam, of course you can. Okay. So you guys did 26, 40, 19 questions all related to psychiatry? Okay. How many of those questions in psychiatry did you guys find in common to our lectures? That is very good to know. Thank you so much for for giving me the feedback. Okay, that is very good to know that most of the questions that you guys found in your world were common to our lectures. So could you guys answer them with confidence? Okay, perfect. Okay, perfect. So, okay, the good. Thank you so much. Okay, that makes us feel really good because our goal is to make first aid easy for you to understand, and our goal is to make you guys excel in you world. So we would like to think that our lectures are working. Okay. Having said that, if there's anything else about our lecture that you need to change, or if you guys have any feedback, please let us know. We are always welcome to make changes. Okay. And have you guys received our invitation to the Google Drive lectures? Okay. So I know a lot of you were looking for lectures regarding neurology. And so did you guys get the lectures you guys wanted? Okay, good. Okay, nice. Okay, so having said that, yes, 10 pictures of neurology. Which 2 p.m. lecture are you talking about, Dr. Maheshwari? Which lecture about 2 p.m. are you talking about? You got a link. When did you get that link? Today. Today we don't have any lectures after 2 p.m. Lecture at 2 p.m. We do not have any lectures at 2 p.m. Just let me check once again if there has been any mistake. Mm. 9 a.m. to 2 p.m. Our lectures are from 9. Oh, okay. Oh, the rest of the lectures of yesterday after 2 p.m. Those were UWorld notes. Oh, I understand. Okay, so those were UWorld notes, which we will post it on the group. Okay, those were UWorld notes, which we will post it on the group. Okay, so the reason why we have not posted those UWorld notes on the group as of yet, that's because the UWorld notes were not enough. So I thought to make a little bit of the notes and add it to the current one, and then we would have added it all together. Okay. Having said that, it's been quite a long time since we all started this discussion. Okay, it's been already 20 minutes. Okay, well, first of all, thank you so much for waiting for all the other students to join. What is the name of the group for Dr. Hydari Step 1 discussion group? I believe we added you to that group yesterday, Dr. Mohammed. Okay, that is the group that we are talking about. Over there, we upload the UL notes. Okay, so first and foremost, thank you so much for waiting for 10 to 20 minutes for everyone else to join. I just wanted to give everyone some time to join, knowing that it's a holiday and everyone would take some time to enter the lectures. But it's already been 24 minutes since we started our discussion. Okay, and having said that, are we ready to do a small discussion of yesterday's topic, review and recapitulation, to see if we stand on the same page, to see if we all stand on the same page, that we remember all the high yields? Are we ready? Okay. Okay, good. Okay. So first and foremost, can I ask you some diagnosis really quick based on the duration of psychiatric illness? Okay. First and foremost, patient with delusion, hallucination, disorganized speech for more than 1 week, but less than 1 month. What is your provisional diagnosis? Okay. More than 1 month, less than 6 months. Okay. More than 6 months. More than 6 months. Okay. Patient has a delusion for more than 1 month. Patient has a single delusion, one or more delusion for more than 1 month, and no other psychiatric illness, delusional disorder. Very, very good. Okay. Patient has patient has three patient has five or more of the symptoms of dig space for more than 2 weeks. Very good. Okay. Okay. Patient has on and off depression for 2 years. Okay. Depression for 2 years, on and off. Okay, very good. This time you. Patient has on and off psychotic episodes for more than 2 years. Patient has on and off psychotic episodes for more than 2 years. Cyclothymia. Very good. Okay. Very good. Next one. Next one is patient has a problem of being extremely afraid of insects. Fast answers, please. Specific phobia. Very good. Okay. Patient has a problem of making public speeches. Social anxiety disorder, social phobia. Okay. Next one. Next one is patient has a problem going out in public spaces and standing in lines or okay. Agoraphobia. Okay. Patient is a young child who has outbursts. Who has outbursts. Young child who has outbursts. Okay, okay, okay. Let's talk a little bit about ego defenses. Okay, let's talk a little bit about ego defenses. First of all, you have a husband who comes back home, shouts at the wife because the husband was shouted on by his boss. What is the ego defense? Good. A victim of sexual abuse, when he sees the abuser, she feels numb. Dissociation. Very good. Dissociation. Okay. A resident physician thinks the world of his attending physician and thinks that the attending physician is one of the best in the world and no one is there that is better than him. Idealization. Very good. Okay. Okay. You guys are doing absolutely amazing. Thank you so much. Okay, good. Next one. Okay. Patient got diagnosed with pancreatic cancer and he or she he or she does not respect the doctor's advice and keeps on continuing with his daily life. Denial. Patient got diagnosed with pancreatic cancer, and now every time someone asks for the diagnosis, he answers by explaining the pathology. Okay. A patient who, okay. Next one is a man who wants to cheat on his wife, but comes back home and accuses the wife of cheating on him. Projection. Very good. Projection. Okay. A stepmother who does not like his stepson, but shows everyone how much she loves him in front of people. Reaction formation. Okay. Reaction formation. Next one. A young child, he does not remember being counseled during a very difficult time in his life. Okay. When his parents were getting divorced, he does not remember. Very good. Okay. Very good. Repression. Very good. Okay. A USMLE Step 1 student, after he gets out from the exam, he decides to think about the results when it's time for the results to be out. Suppression. Okay. A USMLE Step 1 student, after he does not do well in the exam, instead of throwing tantrums, he goes to the gym and he focuses on his next step. Focuses on his next step. Very good. Sublimation. A mafia boss who makes a huge donation to a charity in order to feel good about himself. Altruism. Very good. Okay, that's amazing. Okay, so that's very good. How easy was that for you guys to answer the most hard questions about psychiatry? That is the ego defense mechanisms. Okay, ego defense. Okay, I really, really want to thank you for mastering the ego defenses, because if you are solving psychiatrical questions, then can you guys tell me how important is ego defense mechanisms? How important is ego defense mechanisms? Yes, it's very important. It's very important. If there's one thing that you need to read over and over again, that is the ego defense mechanisms. Okay. Um, okay. So how old do you have to be in order to receive Medicare in the United States of America? How old do you have to be in order to receive Medicare? Okay, because USA cares about people over 65. Very good. Okay. Okay. There is another one. People over 65 and disabled people. Okay, so please write that down. People over 65 and disabled people. Okay. Okay, so a very high yield U-world question. Very high yield U-world question. Okay, so a mother comes to the hospital with her disabled son. Okay, a mother comes to the hospital with her disabled son, and they were in a car accident. Okay, they were in a car accident, and the mother was there with her boyfriend in the car. Okay, and all three of them got into that accident, and now they are admitted to the hospital. Okay, so All three of them needs medical care, but none of them have any health insurance. First and foremost, my first question is, since they do not have any health insurance and they do not have any money, should they receive health care from a US hospital or not? Okay, very good. The answer is yes. Okay, next one. Next one is, if any one of them is qualified for Medicare, who is the patient? Disabled boy. Very good. Okay. Have you guys received this question in New World? Do we have any student over here who has received this question in New World? Okay. When you guys received this question in New World, did you guys answer the right question, right answer? Very good. Okay, so feeling really good about you guys regarding psychiatry. Okay, I'm very happy and very proud. So uh, once again, I know I keep on thanking you guys. That's because I'm really happy with how much you guys have understood and tried to keep in your mind regarding psychiatry. Okay, so that's that. Okay, some last questions before we begin our regular lectures for today. Okay. Okay, so if we have an addict who is thinking of making changes to his life, which stage of overcoming addiction is he in? There is no stage called changing. Okay, but thank you. If an addict is preparing to make changes to his life, preparation, very good. Okay, preparation. If the addict is full on taking if the addict is full on taking actions in order to make changes to his life, if the addict is full on taking actions to change his life, very good. Action, very good. If the addict is maintaining the lifestyle in order to become a better person, maintenance, okay, very good. If the addict goes back and falls into his old habits, relapse, very good. Okay, okay, okay. So, last question. Last questions are about psychiatric emergencies. Okay, the last thing which we studied yesterday. Okay. First and foremost, drugs causing serotonin syndrome. Who do we have any students over here who were not present yesterday? Students from our regular subscribed students. Okay, so hoping everyone was present here yesterday. Okay, so what are the drugs that are causing psychiatric illness? First of all, we have psychiatric drugs and then non-psychiatric drugs. What are the psychiatric drugs? SSRI, SNRI, TCA, monoamine oxidase. Okay, now buspirone, vilazodone, vortioxetine. Okay, do you guys remember taking a bus to a villa and then encountering a vortex storm in the middle? Do you guys remember that mnemonic, that picture mnemonic? Okay, so taking a bus to the villa and then encountering a vortex storm in the middle. Okay, next one. Next one are, well, what are the non-psychiatric drugs? Triptin, linezolid, dexamethasone is not the one, dextromethorphan, okay, St. John's worts, then MDMA, very good. Okay, do you guys remember that small picture I drew out for you guys in order for you to master the non-psychiatric drugs? Okay, tram, and then straight line, a guy trips because he is on MDMA. I mean, he is on dextromethorphan and St. John's worts, taken to the hospital because he started vomiting on ondansetron. After that, when they did some blood tests, they found that the patient is also on MDMA, right? Okay, good. Okay. What will you treat the patient if the patient is diagnosed with hypertensive crisis? phentolamine. Okay, phentolamine. Very good. What will you give to your patient if your patient has neuroleptic malignant syndrome? Okay. Okay. You admit an old patient to your hospital. Okay. You admit an old patient to your hospital. And after you admit that old patient to the hospital, the patient is diagnosed with pancreatitis. So the patient is nothing per oral and is on IV and TPN, meaning total parenteral nutrition. Now, after 2 days, the patient has severe agitation. The patient is delirious. The patient is confused. The patient has sweating, tachycardia, tachypnea out of nowhere, severely agitated. What is your diagnosis? Delirium tremens. Delirium tremens. Okay. Okay. So if you have a patient who is having delirium tremens, okay, if you have a patient who is having delirium tremens, how will you treat that patient? Benzodiazepine. Very good. Okay. Benzodiazepine. Very good. Okay. The next one is how you treat your patient if your patient overdosed on TCA. What will you give to your patient? Antidote. Do not look at the book. Activated charcoal to decrease absorption. Tricyclic antidepressant, hemodialysis, and sodium bicarbonate. Hemodialysis is not used that much for TCA toxicity. It's used for lithium toxicity. Okay, sodium bicarbonate. Okay, very good. Okay, having said that, it's 9:40 exactly on the clock. Okay, so if we have any new students to our lectures, first and foremost, let me welcome you to our lecture. This is the 34th lecture of Dr. Hiley Step 1. Okay, throughout our last 34 lectures, we have finished a lot of high yield topics. Okay, and if you have joined with us from psychiatry, right now we are going to finish psychiatry. If you continue with us in the future, we will be taking the lectures which you have missed once again, because once again, we would be doing it from the beginning. We have a 3 to 4 month session of our lectures in which we will complete the USMLE Step 1 first aid with absolute perfection. At the same time, we would also be doing UWorld notes with it. It's a 4 hour lecture. For the first half an hour to 45 minutes, we do review and recapitulation of our previous topics, talk about the problems and feedbacks. Then we talk about the task in hand, that is read first aid. And in the last hours, what we do is we go through high yield UWorld notes, where we talk about all the answers that are difficult, most of the answers which are around 30 to 40%. We talk about those answers. After that, what we do is we do around five offline UWorld notes every day, which are in association with the topics at hand. Okay, so that's that. As of right now, it's 9:41. So our review and recapitulation section of the lecture is over, and we would be starting our regular task in hand. Before that, we have a question. The question is from Dr. No. The question is, someone who has been on maintenance, even if he returns to drug abuse for 15 years, is he still considered a relapser? Or yes, he is considered a relapser. Okay, even if it's for 15 years, he is considered a relapser. Okay, am I clear? Okay, good. Okay, so good question. Hope that answers. Hope that explanation is okay. Okay, so just give me 1 minute before I pull up our today's topic. So today we are going to talk about psychoactive drug intoxication and withdrawal. Let me just share the screen 1 second. Okay, 1 second. Okay. Okay, so can you guys see my screen? Can everyone see my screen? Okay, is everyone ready to begin? Is everyone ready to begin? Okay, so please let's put our attention into this lecture so that we can finish it fast. And because it's a holiday at the end of the day, the faster we finish, the faster we can all return to our friends and family. Okay, so let's begin our today's lecture. Okay, this lecture should be very easy for you guys. Okay, because we have talked about the neuropsychiatric drugs before. Having said that, uh, we are going to talk about intoxication and withdrawal. It's an absolute favorite topic of mine. Should be a favorite topic of yours too, because you will encounter a lot of patients who will come if you're, especially if you're working in the emergency department. These are the patients that we call after two patients, meaning patients who come to your department after 2 a.m. Okay, so these patients they come with different types of abuses, substance abuses. Out of them, the major substance abuses that we have are either they can be classified into two types basically. These are the uppers and the lowers. Okay, so basically uppers are depressors, meaning depressants, and the lowers are the depressors, meaning depressants, and the uppers are the stimulants. Okay, so first of all, let's talk about the depressants. Number one depressant is alcohol. Okay, and the intoxication are could be classified according to the sign symptoms. Okay, so patients who are on depressants, what they will have is they will have mood elevation. Okay, they will have decreased anxiety, they will be sedated, behavioral disinhibition, meaning that they will be very impulsive. Whatever decision they make, they will stick to it, and respiratory depression. Okay, um, having said that, these things are very easy to understand. I'm pretty sure you guys can easily understand patients who behave who how they behave when they are drunk. Okay, so these are all the same types of behaviors and signs and symptoms. If there is any withdrawal, okay, they will have sign symptoms like this, the ones that we talked about in delirium tremens, such as anxiety, tremor, seizures, and insomnia. Okay, first and foremost, alcohol. If we have a patient with alcoholic intoxication, what will they have? They will have emotional lability, slurring of the speech, okay, ataxia, coma, blackouts. Ataxia, coma, blackouts. Okay, these are still not important. Okay, still not important for first aid. For first aid, what's important is if you have a patient who is an alcoholic, how will you test his liver function test to see if everything is okay, which are related to alcoholic hepatitis? First and foremost, number one is you will do AST to ALT. Okay, AST to ALT. Normally, AST should be lower than ALT, but if the patient is on alcohol and the alcohol is causing damage to the liver, the AST will be 2 times more than the ALT. Okay, so this is very high yield. Okay, so this is very high yield. So use the stars which I'm going to use because they will come in your exams. In the fact that AST is twice as more than ALT. That is one indicator. Another indicator is serum GGT or serum gamma glutamyl transferase. This is a very sensitive indicator of alcoholic abuse. Okay, if you have a patient on alcoholic intoxication, what are we going to prescribe? We are going to prescribe benzodiazepines. Okay, so that's that. Okay. This is basically the timeline. Okay, so timeline from the drinks. We have one question in UWorld which asks you, what is the onset of delirium tremens? Okay, the onset of delirium tremens is from 48 hours after the last drink, and this can last to 96 hours. Okay, so this timeline is important. Okay, before that, what does the patient have? Before that, the patient can have withdrawals, hallucination, tremors, insomnia, but not full onset delirium tremens. Delirium tremens full onset will occur after 48 hours. Okay, will occur after 48 hours. Okay, next one. Next one is, are we clear on alcoholic intoxications? Are we clear on alcoholic intoxications? If you have to do one test to see if the patient has alcoholic damage to the liver, what test will you do? AST, ALT. Okay, AST to ALT before GGT. Okay, AST, ALT, and GGT. Okay, next one, barbiturates. Okay, we have some barbiturates that we talked about before. Okay, can you guys name some high yield barbiturates? Fast answers, please. Can you guys name some high yield barbiturates? Barbiturate drugs. Thiopental, phenobarbital. Okay, good. Okay, so these are barbiturates. They have a very low safety margin. They can cause respiratory depression. Okay, what are the treatments? Treatments are basically symptom management. Okay, symptom management and assist respiration, meaning that if the patient has respiratory depression, what are we going to do? We are going to straight away use mechanical ventilation or intubation for the patient to see uh, if the patient cannot breathe for themselves. Okay, next one is what will happen if the patient has withdrawals. If the patient has withdrawals, the patient will get delirious. What do you mean by delirious? Or delirious means that the patient is not himself. Okay, he is basically saying and doing things that are different from his regular personality. So he will be delirious. Life-threatening cardiovascular collapse, that's another thing. Okay, if I have to ask you a very basic question, if I have to ask you a very basic question, why do we get respiratory depression in benzodiazepine and barbiturate overdose? Can I get some fast answers, please? Why do patients get respiratory depression when they are on barbiturates or benzodiazepines? Anyone? Why do you get respiratory depression? They are depressant drugs. Okay, at which part of your body does the drug go and work in order to cause respiratory depression? Where do they cause the GABA problems in order to cause respiratory depression? Right, respiratory center. Okay, respiratory center in the brainstem. Okay, okay, so that's that. It's a very basic question. Okay, you might get tested on it. Next one is benzodiazepine. Benzodiazepines are much safer than barbiturates. Okay, benzodiazepine can cause ataxia, minor respiratory depression. Okay, okay, high yield treatment. Treatment is flumazenil. Treatment is flumazenil, and they are rarely used as they can cause benzodiazepine receptor antagonist. Okay, but we have to use them with a lot of cautious because they can cause seizures. Okay, this is high yield. This is high yield. Okay, if you do not have a lot of time to read the whole thing, just read the underlines, which I'm doing for you when you guys have less time so that you can do a fast review. Okay, so benzodiazepines treatment is fumazanil. Nothing more you need from over here. Let's move on. Next one is opioids. Opioids is if you are on opioids, or if you have a patient who's on opioids, okay, for example, morphine, heroin, codeines, okay, their intoxication sign symptoms will be at first euphoria. Euphoria means absolute happiness, respiratory and CNS depression, okay, decreased gag reflex, pupillary constriction, okay, pupillary constrictions, seizures, seizures. Now, a lot of students they make a wrong assumption based on the pupillary size in opioids. Okay, always remember that if you are on opioids, you will have pupillary constriction. Your pupils will be constricted. Pinpoint pupil or meiosis. Okay, pinpoint pupil or meiosis. But if you are on amphetamines or caffeine or cocaine, okay, those things will cause mydriasis, meaning pupillary dilatations. Okay, those things, stimulants, will cause pupillary dilatations because stimulants are affecting your sympathetic activity. Okay, so patients will get pupillary dilatations. Opioids will cause pupillary constrictions. Okay, and the most common cause of drug overdose over here even is opioid overdose. So the treatment is very important. Okay, so first and foremost, underline pupillary constriction in your book, and because this is a very important diagnosis to make. if you have to diagnose a patient with opioid overdose, there's basically two things you have to look out for that UR will provide for you. First of all is pupillary constriction, which they will focus a lot on. And the second one is respiratory depression. Okay. Pupillary constriction and respiratory depression is basically a giveaway for opioid overdose, So keep that in mind, pupillary constriction and respiratory depression. If you see these kind of presentations, please consider opioid intoxication. Next one is treatment. How will you treat the patient? Treatment is basically naloxone. Okay, treatment is naloxone. We talked about this before, so we won't talk about this anymore. The thing is, if you get withdrawals, only if the patient is on opioid withdrawals, then the patient will have dilated pupil. Okay. After that, the patient can also get rhinorrhea, lacrimation, stomach cramps. These are not that important. Treatments are important. The treatment for opioid withdrawal, I'm pretty sure we talked about this before in UWorld. Okay. The treatment for opioid withdrawal is symptom management and then long-acting opioids, that is methadone and partial partial opioids, right? Such as buprenorphine. Okay. Buprenorphine. That's that. Okay. Okay, next one. Next one is inhalants. Okay, next one is inhalants. Okay, first of all, inhalants. What are inhalants? Inhalants are the ones where these are usually cheap drugs. Okay, very cheap. That a lot of people, especially homeless people, okay, they have a tendency of abusing these drugs. Especially what happens is they try to breathe in the fumes of certain substances that causes them to get high. Okay, so inhalants. People with inhalants, there is one presentation which first aid will not tell you is let's say that this is your patient who is abusing inhalants. Okay, let's say that this is your patient who is abusing inhalants, and this is the patient's mouth. Okay, this is the patient's mouth. This is the patient's nose. Okay, people who are on inhalants, they will have a red rash like distribution like this. Okay, they will have a red rash like distribution like this along this distribution, because this is the portion of the face which is which through which this is the portion of the face that is exposed to the fumes of the inhalant, so they will cause rash around this area. So this is a giveaway for inhalant abuse, and this is important for UWorld because they will describe you multiple questions in UWorld where they will tell you that you have a patient who has euphoria, slurred speech, rash around, euphoria, slurred speech, disorientation, drowsiness, okay, and rash. They will have rash around the face, which are exposed. They have rash around the nose and the mouth, okay. And the thing is, a lot of the patient, when a lot of the students, when they hear disorientation, drowsiness, and rash, the first thing they think about it that if it's a female patient, it's SLE. Okay, it's SLE. But there are some questions where they will tell you that the ANA was negative, and all those they will try to exclude it out. But also remember that SLE rashes are butterfly rashes. They are not a rash which will only be present around the nasal and mouth area. So that's that. So keep that in mind. It's extremely important. Okay, next one. Okay, next one is how do you feel when you are withdrawn from inhalants? That is basically you irritability, dysphoria, headaches. These are not high yield. Okay, these symptoms overlap with all the other symptoms. So that's that. So these are basically the high yield questions. So please make sure that you remember that rash around rash around the nose and rash around the mouth is very important for inhalants. Okay, next one. Next one is stimulants. Next one is stimulants. Okay, so how do patients act when they are basically on stimulants? So we have stimulants such as amphetamines, even caffeine is stimulant. Okay, how many of us over here has made caffeine our best friend? Okay, caffeine is my best friend. How many of us over here are dependent on our friend caffeine? Okay, how many of us over here are dependent on our friend nicotine? Okay, very good. Very good. That's one thing which you should not get dependent on. Okay. But caffeine. Okay. Every one of us loves our friend caffeine. Okay. Okay, good. So the first drug that I want to talk about is amphetamines. Okay, amphetamines. First and foremost, if I ask you, do we have any students over here who is a big fan of having Americano coffees or dark coffees or black coffees? Extremely dark and extremely hardcore coffee. Okay. How do you guys feel when you are on these strong coffee drinks, strong caffeinated drinks? How do you guys feel? First of all, let's talk about your mood. How do you guys feel after you have that dark coffee? Okay, first of all, your mood is elevated. Do you feel hungry when you are on coffee? When you are on caffeine? Do you feel hungry? No. So decrease appetite. Okay. Are you excited when you are on caffeine? Okay, good. Okay. Do you feel the need to sleep after you have a huge glass of that good old dark coffee? Okay. No. How about your heart rate? How about your heart rate? Is it normal or increased? High. Okay. Is there a possibility that that caffeine can cause you anxiety or anxiousness? Have you guys felt like that before? I know I have. Okay. Anxiety or anxiousness. Okay. So mood elevation. Okay, good. So mood elevation, decreased appetite, insomnia, cardiac arrhythmias, tachycardia, anxiety. These are all the sign symptoms that you have to look out for in case of stimulants. Okay. In case of stimulants. So that's exactly what it is. Okay. And another one is if you do you remember that one time? Do you guys remember that one time when you guys had so much coffee that you guys stayed awake for 2 days straight? And after the second day, your body crashed and you fell into bed and you slept straight for 12 to 13 hours? Okay. Okay. I'm sure one or two of you guys have experienced that. Okay. Now, this is known as post-use crash burn. Okay. What happened to you guys was post-use crash and burn. Okay, this includes increased appetite, sleep disturbance, and vivid nightmares. Okay, so that is what you have to look out for in withdrawals. Okay, that is what you have to look out for in withdrawals. Okay, amphetamines. Let's talk about amphetamines. How do people feel when they're on amphetamines? They're basically the more or less the same thing how they feel when they are on caffeine, except the fact that it's a bit more than it's a bit exaggerated feeling. So they feel euphoric, grandiose, meaning that they're the best in the world. Pupillary dilatation. Okay, that's what I told you. Stimulants can cause pupillary dilatation, prolonged wakefulness, hyper alertness. They're very hyper. Fever, fractured. Okay, fever, fractured teeth, skin excoriations with methamphetamine use. Okay, skin excoriation with methamphetamine use. Have you guys ever seen an amphetamine abuser? Even not if not in real life, then in movies, maybe movies. Amphetamine abusers. Okay. Uh, have you guys ever? Do you guys know how people abuse amphetamines? Do you guys know how people abuse amphetamines? Is it through IV? Um, is it oral? Okay, so first and foremost, yes. So first and foremost, people, okay, they have people who abuse amphetamines. They have this kind of a paper. This paper is an aluminum foil paper, okay, and then they place that amphetamine drug over here. Okay, they place that amphetamine drug on the aluminum foil. Then they use a lighter to light the foil up. Okay, this results in burning of the drugs, which results in fumes. And then a pipe. They use a pipe to inhale the fumes. Okay, they use the pipe to inhale the fumes. Okay, so what this does is this type of amphetamine use by using a pipe, they can result in weakening and fracturing of the teeth. Okay, the reason why I showed you the mode of use is because you have to know the mode of abuse when you have to make the connections. Okay, so this can result in weak teeth, fracturing of the teeth, skin excoriations. Okay, they are very bad for your skin. And in severe cases, the most common cause of death of amphetamine abuse is cardiac arrest because the patients can get severe life threatening arrhythmias, ventricular tachycardias, ventricular fibrillation, and sudden cardiac arrest. Patients can also get seizure. Okay. What do we use for patients who are agitated? We use benzodiazepines. Once again, our friend lorazepam will help us calming down the people who are on amphetamines. Okay, next one. Next one is caffeine. Okay, caffeine is palpitation, agitation, tremor, insomnia. We all talked about this. This is how you feel. You have just said so. And what would happen if we stop? All of a sudden, we can get a caffeine headache, difficulty in concentration, and flu-like symptoms. Okay, how addictive is caffeine? How addictive is caffeine? Do you guys have any idea how addictive caffeine is? Okay, moderate. Okay, so according to recent according to recent research studies, caffeine is almost, or if not, is just as addictive as cocaine. Okay, caffeine is almost, or if not, more addictive than cocaine. Okay, so the fact that medical students and physicians, we abuse coffee like the way we do, okay, and we cannot function without caffeine in one way or another, although you cannot call us abusers, but we are dependent on caffeine, okay? So I would highly advise my students that if you have already started to be dependent on coffee, I would advise you guys to slowly make a switch to tea, okay? Because tea contains a substance. Do you guys know the name of the substance which tea contains, which can also help you get rid of your? Okay, tea contains a substance known as tannin, TANIN, tannin. Okay, tea contains a substance called tannin. Tannin works in the same way, more or less, like caffeine, but it's less dependent. So that's that. Okay, so it's about time we start making a change. It's not good for our body, not good for your heart. Okay, not good for your anxiety, agitation. Which one, green or black? Okay, every tea is good. Okay, green or black, it does not matter. Every tea leaf has tannin. Okay, but that's that. Okay, having said that, let's move forward. Next one. Next one is cocaine. Okay, cocaine. What happens to a person when they are on cocaine? First of all, they have an impaired judgment, pupillary dilatation, hallucinations. Okay, hallucinations, tactile hallucinations. What is the name of tactile hallucinations that we see in cocaine? What is the name of the tactile hallucinations that we see in cocaine? Can I get some fast answers, please? Cocaine bugs. Okay, cocaine bugs. Okay, tactile hallucinations. They get paranoid, angina, sudden cardiac death. Okay, same thing more or less that's happening in amphetamine, but a bit more. Okay, okay. If you have a cocaine, how first and foremost, how do people abuse cocaine? What is the mode of entrance of the drug? Sniffers. Okay. Does anyone have any idea about how people abuse? I mean, does anyone have no idea about people who have abused cocaine? Okay. Let me just point it out. First of all, cocaine is sold in bags, little bags. Okay, over here. Okay, these bags are more or less called these bags are called dime bags. Okay, these bags are called dime bags. Okay, it's not important to know what these bags are called, but since you are going to work over here in US, you guys should know exactly what's happening. Okay, so these small bags are called dime bags. Each of these bags could be around $50 to $100. Okay, these bags, they contain the cocaine powder, and people take out the powder and put it on a smooth surface. They break down the powder with let's say with a piece of card. Okay,
After they break it down, they make lines. Okay, they make lines like this. Okay, so they have lines of sniffs, and then this is the patient's nose. Okay, this is the patient's nose, and what they will do is they will use a stick or a rolled up cash paper. They will use a stick or a rolled up cash paper. They will put one stick into their nose, another stick's end will be over here on the coke. They will put one hand on one nostril and pull really hard with this drug going straight inside the nose. This drug will go straight inside the nose. Okay, through the nose, it will go and reach the respiratory system. Now, if the person is using coke for a long period of time, and cocaine, what that will do is it is very, very injurious to the mucosa of the nose. Okay, can there be ulcers in the nose or perforation of the nasal septum? Yes. Okay, so that is one thing that you have to look out for. Okay, so what happens is over time what happens is, if you have a nose like this, and this is the nasal ulcer, I mean the nasal septum, the nasal septum will have an opening like this. Okay, this is absolutely horrific. The nasal septum will have an opening like this, in which you can literally pass a thread, and the thread will go through one nose and come out through the other nose. So perforations of the nasal septum. Okay, so this is one thing that you have to look out for in your patients with cocaine abuse. Okay, if you have a patient who has a nasal ulcer along with sign symptoms of facial pain, headaches, and sign symptoms of nasal ulcer, what is your diagnosis? Fever. The patient also has fever. What is your diagnosis? Nasal ulcer, facial pain, headaches, sinusitis. Very good. Okay, very good. Very good. Sinusitis. Okay. Not everyone with a nasal ulcer is a cocaine abuser. Okay, that's what we have to keep in mind. Okay, the next time you see a nasal ulcer, that's not the first thing you have to look out for. You also have to look out for all the other sign symptoms of the patient to see what's going on. Okay, so the URL will have questions where they will ask you whether you can successfully differentiate between cocaine abuse and sinusitis. Okay, so chronic use can lead to perforations of the nasal septum. Why? Because cocaine is a vasoconstrictor, and this can result in ischemic necrosis. Okay, ischemic necrosis. Treatment is first of all benzodiazepine. Okay, if you have a patient who is abusing cocaine, can you give them alpha blockers? Can you give them alpha blockers? Fast answers, please. Can I get fast answers? Okay. Okay, no, you cannot give them alpha blockers because there will be compensatory action or overaction of the beta agonists. Okay. Okay, next one. If you have a patient who is abusing cocaine, can you give them pure beta blockers? Purely pure beta blockers? No. Okay, if you give them pure beta blockers, they will have severe alpha agonist hyperactivity. They might even die from cardiac arrest. Okay. If you have a patient who is on cocaine and you give them mixed alpha and beta blocker, mixed alpha and beta blocker, can you give them mixed alpha and beta blocker? Yes. Okay. Okay, good. So we can give them mixed alpha and beta blocker. An example of that kind of a drug is known as labetalol. Okay, labetalol. But the number one drug that we use for cocaine abuse is benzodiazepines. Okay, benzodiazepines is the number one drug. Okay, now the last one. The last one is nicotine. Okay, so what is nicotine? Nicotine is basically the substance that we get when we smoke cigarettes, or when patients smoke cigarettes. Okay, so intoxication can cause restlessness if we do not get if we do not smoke cigarettes. We feel irritated, anxious, restlessness. Okay, decreased concentrations, appetite, and weight will increase. Treatments are very easy. Treatment is nicotine patch, gum, or lozenges. But what we can also give is, this is important for you world. Okay, bupropion and varenicline. Okay, please underline this. Okay, nicotine. Okay, they act more or less as to some level of nicotine agonists. Okay, so bupropion and varenicline. Bupropion and varenicline. Please remember these two drugs for the nicotine abusers. Okay, what can we give as alpha blocker in cocaine? We do not give solely alpha blockers. Okay, we do not give sole alpha blockers. We have to give a mixture of alpha. Oh, why? Okay, good. First and foremost, Dr. Hassan, if you have a patient who is abusing cocaine, what type of autonomic overdose will the patient have? Sympathetic or parasympathetic? Dr. Hassan, the question is for you. If you have a, how can they have a parasympathetic overdose? Cocaine is a stimulant. Cocaine is a stimulant. Do you guys know how cocaine act? Okay. Do you guys know how cocaine act? Okay. What is the mechanism of action of cocaine? Okay. Mechanism of action of cocaine. This is a presynaptic neurotransmitter. Synapses, postsynaptic neurotransmitters. Okay. Postsynaptic neurotransmitters. Over here, we have reuptake channels. We have serotonin reuptake channels, dopamine reuptake channels, norepinephrine reuptake channels, okay, noradrenaline reuptake channels. Cocaine is a master blocker of all these channels. Cocaine blocks all these channels, okay? If cocaine blocks all these channels, we have excess serotonin, dopamine, norepinephrine, adrenaline. All these things, will they cause you to get stimulated or inhibited? Fast answers. I need some fast answers, please, because I have to move. Stimulated, very good. So if they are stimulating you, then they are sympathetic. Now, if a patient is on a sympathetic overdose, what are the sympathetic receptors in the body? Alpha and beta, am I correct? Alpha agonists and beta agonists, alpha 1, alpha 2, beta 1, 2, 3. If I only block the alpha, will it not result in me exposing my beta agonist to to the excess of norepinephrine and adrenaline? You know? Okay. And if I tell you that right now, which beta receptor is there in the heart? Which beta receptor is there in the heart? Beta 1. Okay, beta 1. Okay, good. And now the thing is, right now, if you only block the alpha receptor, and now all this excess serotonin, dopamine, norepinephrine, they are going to go and bind to the excess beta 1 in the heart. Will this result in extreme tachycardia? Yes or no? Fast answers, tachycardia. From this tachycardia, is it possible that you can get arrhythmia, life-threatening arrhythmia? Okay. From this arrhythmia, can the patient go to ventricular tachycardia and ventricular fibrillation? Okay. So if he does, and from there, he can go to sudden cardiac arrest and he can die. He can die. Okay. So this is the reason why we will not give the patient solely alpha blockers or solely beta blockers. Am I absolutely clear? Okay. Okay. You guys have to be very, very cautious when you administer drugs to abusers. Okay. Because first and foremost is do no harm. Okay. First and foremost is do no harm, meaning that if you are confused about administering a drug to a patient, it's always better to it's always better to make judgment calls based on the fact that you have asked someone if you are not clear. Okay, why am I talking about do no harm? Because there's a question in UWorld where they will tell you that an intern physician is given the task of prescribing a beta blocker to a cocaine abuser. Okay, now what should the intern physician do? The intern physician uh, has read somewhere that you cannot give beta blockers to cocaine abusers. Now, what should the intern physician do? The answer lies in the fact that the intern physician should go and double check with the attending physician that whether he or she should prescribe the beta blocker or not. Okay, so this is one of your question in UWorld. So that's that. Okay, are we all clear on stimulants? Are we all clear on stimulants? Okay, let's move on. Okay, next one are hallucinogens. What are the hallucinogens? First of all, let's start by talking about one of the most important drugs for USMLE Step 1. Okay, that is phencyclidine, or it's also called PCP, PCP, phencyclidine or PCP. Okay. So this drug over here, okay, they create a lot of noise in you world. Okay, so we have to read everything about phencyclidine. Phencyclidine is very important as a hallucinogen. First of all, how will you know that a patient is on phencyclidine? Okay, first and foremost, what is phencyclidine? I just want to show you a quick picture. One second. Okay, so this drug over here. Okay, so this drug is known as phencyclidine or PCP. Okay, PCP. What you can do is there are multiple ways how people can abuse PCP. First is via IV, or they can use fumes, or they can use it to sniff, or they can smoke the PCP. Okay, so this is basically the drug. This is a hallucinogenic drug. Okay, which are sold to people in parties, and what would happen is after patients they intake PCP, they can get very violent. They get very impulsive psychomotor agitations. Okay, tachycardia, hypertension, analgesia, meaning no matter how much you hurt them, they will not get hurt. Okay, psychosis and deliriums and seizures. And the most common way that you will throw the question at you is they will tell you that you have a patient who comes to the hospital from a party by I mean after a party cuffed by the police. So the police has brought the patient to your hospital. The patient is extremely violent. The patient is having seizures. The patient is very impulsive. Okay, and this patient was doing very well. When you ask him when did his sign symptom starts, and he will tell you that I was doing well, and then what happened was okay, the patient will not tell you. In the UL question, the question goes something like this. First of all, a patient comes to the hospital cuffed by the policeman, and the patient has friends with him. The friends will tell the doctor that the patient was doing well before he went to the bathroom. After he came out from the bathroom, out of nowhere, he started acting very violent, agitated, and impulsive, and he got into a fight. Okay, he started fighting people. Okay, if you get any question like this, that people coming to the hospital from a party, okay, this and that, please try to consider PCP intoxications or PCP overdose. Okay, so if the patient was doing well before going to the bathroom, meaning that after he came outside of the bathroom, he just got out abusing his PCP, and which is causing all his sign symptoms. Okay, trauma is the most common complication. So the thing is, since the patients have analgesia, they do not feel the pain, so they can get into fighting and they can get hurt, but they will not understand. So that is a very important thing. PCP. Next one is LSD. LSD is lysergic acid diethylamide. Lysergic acid diethylamide. Okay, so what is LSD? LSD is basically a perceptual distortion. They can cause depersonalization, anxiety, paranoia, psychosis, flashback. Okay, have you guys ever seen movies where people have you guys seen movies where people abuse LSD, or seen people abusing LSDs in front of you ever? Okay, so okay, okay, LSD. How does LSD look like? Okay, okay. This is how a vision of an LSD of a person on LSD. This is basically how they take the LSD. So this is sold as a piece of paper. They put it on the tongue, and they put their and then they take their tongue inside, and this resolves in the fact that the LSD dissolves in the tongue. This piece of paper, it dissolves in the tongue, and it is directly absorbed by the veins, by the surrounding superficial veins, and then they reach the blood directly. So what happens is after the patient they abuse this kind of drug, what happens is they go into a severe hallucinogenic episode, okay, where they start seeing things that are not there. Severe visual, auditory, tactile, all types of hallucinogen takes place over here. So that is due to LSD. So all types of hallucinations are basically happening at the same time. So the patients can have perceptual distortion, meaning that they will lose focus of the reality, depersonalization, they will not realize who they are, anxiety, paranoia, flashbacks. Okay. Okay. Did you guys understand LSD? Okay. Who are the most common patients who can abuse LSDs or will come to the hospital with LSD overdose? People who teens, okay, teens, young patients, and people who have just come from a big concert or parties. Peace people. Okay, peace people. By that, I'm pretty sure Dr. Karbasi means hippies. Okay, so I doubt. Okay, I doubt peace people will abuse LSD. But what I do know is people over here, when they come out from concerts or parties, okay, or raves, okay, then they are more prone to be LSD abusers. Okay, that's that. Next one is, have you guys heard about marijuana? Have you guys heard about marijuana? Oh, I'm so sorry to hear that. Okay, that is horrible. Very, very sorry. Okay. Have you guys heard about marijuana? Okay. Have you guys ever seen anyone abuse marijuana? Okay, it's to be honest, cannabis is legal in some states it's in some states of USA. Okay, almost also legal in Canada. For that. Okay, so cannabis abuse is also a problem. Okay, so cannabis abuse. What can cannabis abuse do? What can cannabis abuse do? Okay, so cannabis is basically it contains a very addictive substance called THC. THC stands for tetrahydrocannabinol. Okay, so THC, this can cause euphoria, anxiety, paranoid delusion, perceptions of slow time. Okay, first and foremost, can cannabis cause conjunctival injection? Yes or no? Fast answers, please. Okay. If you have a young patient who comes to your hospital with dryness of the mouth, conjunctival injection, increased appetite, slow responses, patient falls into laughter every time you tell them something, everything is funny to them. Okay. Does this sound like a cannabis abuse? Yes or no? Young patient who comes to your hospital with conjunctival injection, increased appetite, dryness of the mouth, patient starts laughing whenever you ask them something. Okay, so these types of presentations are your presentations for cannabis abuse. Okay, the pharmaceutical form is dronabinol that is used as an antiemetic in chemotherapy. Okay, some forms of THC are used as anti-cancer medications and appetite stimulants in AIDS. Okay, the patients can get irritable. The patients can have anxiety, depression, insomnia, restlessness, and decreased appetite if they are withdrawn from marijuana. Okay, okay. Before we move forward, there's another small drug again I want to talk about. That is MDMA. MDMA is basically ecstasy. Okay, okay. Ecstasy is once again. What is ecstasy? This is you. This can cause euphoria, hallucinations, disinhibition. Okay, have you guys seen people use ecstasy in movies? Have you guys seen people take ecstasy in movies? Okay, ecstasy is basically a drug which you take during parties and okay, or concerts. Okay, basically that drug, what it causes severe euphoria, hallucinations, disinhibition, increased thirst. Okay, that is important. And there's another thing that I want you to understand is bruxism. Bruxism is very important for ecstasy. Bruxism is basically teeth grinding. The patients will grind their teeth. Okay, so teeth grinding is very important for bruxism. Distorted sensory and time perception, life-threatening effects, hypertension, tachycardia, hyponatremia. These are not that high yield, but you can tell when the patient is on ecstasy because they will have sign symptoms of stimulants. Along with that, the patients can have bruxism. Okay, bruxism. So underline bruxism and give a star mark. Okay, this is a very particular to ecstasy. All the others will overlap with the other sign symptoms of stimulants. Okay, that's that. Okay. Okay, so I'm gonna give you some presentations and I will need some fast answers to see if you guys have understood. Okay. Okay, so first of all, you have a patient who comes to the bruxism. Bruxism means teeth grinding, grinding your teeth. Okay, teeth grinding. Okay. First of all, I will give you some presentations to see if you guys have understood the drugs. If you have a patient who comes to your hospital with severe respiratory depression, okay, severe respiratory depression, which drug do you think the patient has overdosed on? Opioids and barbiturates. Very good. Now, if I tell you that the patient has respiratory depression and pinpoint pupil, pinpoint pupil, opioids. Okay. If I tell you a patient is admitted to the hospital who is uh, who is having slurred speech, disorientation, and the patient has rash around the nose and mouth. Patient has rash around the nose and mouth. Okay. Next one is if I tell you a patient comes to the hospital with increased agitation, anxiety, nasal ulcer. Okay. If I tell you a patient comes to the hospital from a party, patient is extremely violent, patient was okay before the patient went to the bathroom. Okay, very good. Okay, very good. Next one. Next one is alcohol use disorder. Okay. So physiological tolerance and dependence on alcohol with symptoms of withdrawal when intake is interrupted. Okay. So a lot of people we know, we know that alcohol use is very common, and the alcohol abuse is more common than the use. Okay. So people abuse alcohol like crazy. What are the complications of alcohol use? First of all, people get severe thiamine deficiency. Okay. If you are on alcohol, you can get B1 deficiency, alcoholic cirrhosis, hepatitis, hepatitis, pancreatitis, peripheral neuropathy, and testicular atrophy. Okay. How do you treat a patient with alcohol abuse? First of all, you give them naltrexone. Okay, what is naltrexone? Naltrexone is basically, do you guys remember what naltrexone is? What is naltrexone? Nasal ulcer is seen more in cocaine. What is naltrexone? Okay, it's an opioid antagonist. Very good. So we give naltrexone, which can reduce the cravings. Okay. Another one is we can also give acamprostate, disulfiram. Okay, acamprostate and disulfiram. What would happen if we give a patient disulfiram who is having alcohol? If the patient has metronidazole, when the patient is having alcohol and the patient has metronidazole, what will happen? What is the name of this type of reaction? What is the name of this type of reaction? Very good. This type of reaction is known as disulfiram-like reaction. Okay, disulfiram-like reaction. Basically, patients will have headache, vomiting, decreased consciousness. Okay, and they will feel extremely horrible after they drink the alcohol. Heaviness of the head. Okay, nausea. Okay, these type of things. So in order for patients to stay away from alcohol, we can give them disulfiram like drugs, and these drugs, what they will do is they will cause some sort of a sulfur like problem. Okay, and then the patients can get these signs and symptoms. Why can alcohol cause hepatitis? First of all, which zone of the liver is alcohol causing the damage in? Zone 1, 2, or 3? Do you guys remember? Very good. Okay, very good. So we have different zones of the liver, which we talked about in GI physiology. So we have zone 1, 2, 3, zone 3. Over there, alcoholic hepatitis is causing problems. And over there, long-term use of alcohol can cause death of the hepatocytes and inflammation of hepatocytes. And inflammation of hepatocytes can cause hepatitis, alcoholic hepatitis. Okay. Okay. We have certain groups over here that are called AA. AA is known as Alcoholic Anonymous. Okay, AA are basically groups of previous alcoholics. They're sober. They get together and they help out other alcoholic people to stay away from that kind of lifestyle. Okay, is that a very positive thing to do or not? Is that a very positive thing to do? a group of alcoholics who are sober now helping other people. Yes, it's very positive. It's very positive. They're helping out. They're helping out a lot of people. Okay, so Alcoholic Anonymous, what they do is they use these drugs such as acamprostate, disulfiram, and naltrexone. Okay, they use these drugs to cause they use these drugs to cause decreased cravings of the patients. Okay, so there are some questions in UWorld where they will talk about Alcoholic Anonymous. Okay, I just wanted to let you guys know what Alcoholic Anonymous is. So that's that. Okay. Okay. Next question is from Dr. Hassan. Okay. Okay. So what is acamprostate? Acamprostate is basically a drug that is used to treat that is used to treat alcoholic cravings. Okay, it is used to treat alcoholic dependence, and basically acamprostate. What this is acamprostate is more or less like a neuromodulator, if you will say. So what happens is it's an anti-craving drug, which will help the patients maintain abstinence. Okay, the mechanism of action is not really known. Okay, but the thing is, this drug acts on the neuronal NMDA and calcium channels. Okay, neuronal NMDA and calcium channels. NMDA. Okay, it helps with the neuronal NMDA and the calcium channel, and it modulates the release or it modulates the release of glutamate. Okay, increases or decreases the release of glutamate because this helps with I'm sorry, once again. Okay, NMDA. Acamprostate is an NMDA modulator. Okay, so it increases or decreases the release of glutamate to cause decreased cravings for alcohol. Okay, so that's that. Next question is, okay, next question is cravings. What do you mean by cravings? Cravings meaning, let's say that okay, Dr. Mohammed, is there one food that you really like to eat? One particular food? What is your favorite food? Meat. Okay, good. Okay, so let's say kebab. Okay, so let's say that our friend Dr. Mohammed over here loves having kebab, like how I love kebab. Okay, let's say it's 3 at the middle, it's 3 a.m. at night. Okay, you do not have any kebab in the house, but you really want to have kebab. Have you ever had that feeling? Have you ever had that feeling? 3 in the morning, you do not have kebab in your fridge, but you really want to have kebab. Have you ever had that feeling, Dr. Muhammad? Yes, that feeling is known as craving. Okay, that feeling is known as craving. Have you guys watched Man versus Food on TLC ever? Have you guys watched Man versus Food on TLC? Okay. Okay, so when you guys saw Man versus Food, you you know there are certain times when you see some things that you are welcome. You see certain foods in Man versus Food, and you want to eat them, but you can't. Okay, so that feeling over there is that feeling of craving. Okay, so I'm pretty sure you guys would know what craving is. So that's that. And okay, hope explanation helped. Let's move on. The next one is Warnick-Korsakoff syndrome. What is Warnick-Korsakoff syndrome? This results from vitamin B1 deficiency. Okay. Can you guys tell me what are the three things that we see in Warnick's in encephalopathy? First, fast answer: confusion, ophthalmoplegia, and very good. Confusion, ophthalmoplegia, and this may progress to irreversible memory loss, confabulation, and personality changes. If personality changes and confabulations are added to these signs and symptoms, then this is known as Korsakoff syndrome. Then this is known as Korsakoff syndrome, not Warnick's encephalopathy. Okay, this is known as Korsakoff syndrome. Okay, and once again, if a patient comes to your hospital who is an alcoholic, patient has hypoglycemia, will you prescribe the patient glucose before you prescribe vitamin B1? Okay, very good. So you will prescribe them B1 and then you will prescribe them glucose. Okay. Okay, very good. Having said that, we are done with psychiatry. Now we will move on to psychiatry pharmacology. Okay, now we'll move on to psychiatry. Why is that so? Okay, so that's a good question. So, as I have explained it before, if you have a patient who is on alcoholic, who is an alcoholic, what is the most common vitamin deficiency that has for alcoholics? B1 deficiency. Very. And is B1 important for glucose? Yes or no? For glucose metabolism? Yes or no? Thiamine. Okay. At which step of glucose breakdown product do you need thiamine? At which step of glucose breakdown product do you need thiamine? Pyruvate dehydrogenase complex. Very. Pyruvate dehydrogenase complex has thiamine in it. Okay. Now, if I tell you that you do not have enough thiamine in the body in an alcoholic patient, then you give that alcoholic patient glucose, will the body use the stored thiamine to metabolize that glucose? Yes or no? Yes. Okay. So if the body uses the rest of the excess thiamine that the body had, will there be complete thiamine deficiency? Yes or no? If there is complete thiamine deficiency, there are certain parts of the neurophysiology, such as mammillary bodies. They depend on thiamine function. If there is complete depletion of thiamine, will there be hemorrhage of the mammillary body? Yes or no? Because they depend on thiamine, so they can have severe necrosis and apoptosis. Okay, so if there is a hemorrhagic necrosis of the mammillary body, and we know that the mammillary bodies are an important segment of the limbic system. Okay, do you guys remember Hammett? Hammett, you guys remember Hammett? How in the M, Hammett is the mammillary body for the limbic system, and the limbic system is responsible for maintaining our emotion, prevents confusion, and all these kinds of things. So this will result in severe confusion, personality changes, memory problems, and the patients can have full-on Wernicke-Korsakoff syndrome. Okay, has that explanation cleared why we need to prescribe B1 before we use glucose? Okay, good. So that's that. Okay. Okay. So having said that, now we are going to begin psychiatric pharmacology. Okay. Psychiatric pharmacology. There are a lot of things which we will learn today. Okay. Before we begin psychiatric pharmacology, do you guys want to take a 5-minute break before we begin? 10 minutes is too long. Okay. We won't take that 10-minute break up later. We will take 5 minutes break. Okay. Before we begin psychiatric pharmacology. Okay. So we are going to take a 5-minute break. Okay, so can you guys hear my voice? Is everyone back from the break? Okay, good. Okay, is everyone back from the break? Okay, so we are going to begin with psychiatric pharmacology. Okay, we're done with our 5 minute. It's 10:45 as of right now, and we are ready to begin. Can you guys see my screen over here? Can you guys see my screen? Is my screen visible to everyone? Oh, okay, good. So to begin, the first thing that I want to talk about today is I want to begin the pharmacology section. Okay, with our discussion on psychotherapy. Okay, what is psychotherapy? Psychotherapy, first of all, there are different ways how by which we can differentiate psychotherapy. Okay, so there are different types of psychotherapy which we can use. First of all, the number one therapy that we can use first of all is behavioral therapy. Okay, behavioral therapy. So what is behavioral therapy? Behavioral therapy is the type of therapy which is used by a psychologist or by a psychiatrist, okay, psychologist or a psychiatrist to identify the problem which is causing the psychological stressor in the patient. Okay, if for example, if you have a patient who has phobias to insects, okay, to phobia to insects, if we teach those patients to handle insects, for example, let's say instead of giving them live insects, we give them insects made of plastic, and we ask them to change their behavior related to to the insects. Do you think that will help them out with their phobias? Yes or no? You think that will help them out with their phobias? Yes, will help them out with their phobias. Okay, so that's that. So these type of therapy is known as behavioral therapy. So this can be used for specific phobias in which, for example, patients are taught on how to change their behaviors related to the stressors. Next one. Next one is cognitive behavioral therapy. Cognitive behavioral therapy. First of all, if we have a patient who is an alcoholic, uh, do you guys realize that there are certain situations when the alcoholic gets stressed out and he needs alcohol, he needs to do depend on alcohol to get rid of that stress? Yes or no? Trigger factors. Correct. So if we as psychiatrists or psychologists, if we can point out to those patients that look, you do not need alcohol. The only problem is every time you have this stress points in your life, you feel like you have to go back to alcohol. So only try to fight your alcohol cravings at those stressing points. If the patient can identify the stressing points, will this help the patient out to avoid alcohol consumption? Yes or no? Okay. So if you can help the patient to avoid the alcoholic stressors, if you can help the patient to avoid the alcoholic stressors, this will allow the patient to stay away from alcohol. This type of behavioral therapy in which the physician is helping the patient out to identify the stressing point. This is known as cognitive behavioral therapy. This is known as cognitive behavioral therapy. Okay, next one. Next one is interpersonal therapy. Interpersonal therapy. What is interpersonal therapy? If you have a room in which you have two alcoholics together, okay, both of them used to use alcohol, now they do not use alcohol at all. When both of them talk to each other, can the both of them help each other out to stay away from alcohol? Yes or no? Yes. Okay. I will repeat CBT. Okay. Do not worry. Just let me finish the psychotherapy lectures and then I'll go back. Okay. I'll go back to repeating CBT and all the other confusion. Okay. So what I was talking about, let's focus on interpersonal therapy first. Then we will go back to CBT once again. Interpersonal therapy. First of all, if you have a room in which you have two alcoholics together, if they were previous alcoholics, both of them can help each other out. Am I correct or not correct? Again, Yes, they can help each other out. These type of therapies in which both of the experienced abusers can help each other out. This type of therapy is known as interpersonal therapy. Interpersonal therapy. Okay. Okay. For all the students who have not understood what CBT is cognitive behavioral therapy. Now, once again, if you have an alcoholic, do you guys realize that alcoholic patients have certain stress points in their life when they need to depend on alcohol? And at those certain stress points, they drink alcohol a lot. Is it true or not true? That's true. Yes. So if you, as a psychiatrist or a psychologist, if you guys help the patients identify that stress point in their life and tell the patient that this is the stress point in your life in which you consume a lot of alcohol. If the patient can identify the stress points, can the patient stay away from alcohol? Is it easier for the patient to stay away from that alcohol? Yes. So this identification of stressors in order to stay away from substance abuse is known as cognitive behavioral therapy. This is known as cognitive behavioral therapy. Okay, am I clear? Okay. BT is behavioral therapy. Okay, BT is behavioral therapy. Next one. Next one is dialectical dialectical behavioral therapy. Dialectical behavioral therapy. Okay. Okay. Dialectical behavioral therapy. What is dialectical behavioral therapy? Dialectical behavioral therapy is basically, let's say, do you guys remember we talked about a patient with histrionic personality disorder? Histrionic personality disorder felt the need to get attention, you know? Okay. If you really sit down with that patient with the histrionic personality disorder, okay, if you really talk to the patient and try to understand what his or her problem is, where they're coming from, what their motive is, what they get out of this, how they're affecting the people around them, how the people around them sees them and or perceives them, or how they perceive the reality. When they understand these things and you talk to them very clearly by using a dialect or improving your communication skills or conversation, do you think there's a possibility that person with histrionic personality disorder, this can be of use and their personality might change? Yes, if you can really get through to them. This type of therapy in which you use a conversation and communication skills to change the behavior, this is known as dialectical behavioral therapy. Okay. This is known as dialectical behavioral therapy. Okay. Next one. Next, the last one is supportive therapy. Okay. What is supportive therapy? Supportive therapy is also for narcissism. Supportive therapy. What is supportive therapy? When a patient is when a patient is undergoing something really bad, for example, the patient is undergoing something such as bad as complicated grief. Okay, when the patient is undergoing something such as bad as complicated grief, if you show empathy to the patient, if you empathize the patient and tell the patient that I know it must be extremely difficult to cope with the death of your husband who has passed away. I know you guys were always together, okay, but over time, this will get very, very easy. This is a natural process of life. People are born, they live their life, and then they die, and other people will die too. But we have to move on. And if you empathize with the patient and then you try to get through to them, do you think that will work for patient with complicated grief? As a Okay, yes. Okay, it might work. Okay, this type of therapy where you are trying to empathize with the patient's problem, this is known as supportive therapy. Are we clear on supportive therapy? Okay, now I'll do a small test to see if we all understand. First of all, if you have a patient with phobia and you expose that patient to the stressor and try to change their behavior, so what type of therapy is BT? Okay. Next one is if you have an alcoholic and you point them out the stressing points in their life in which they only take alcohol, CBT. If you use your conversation or communication skills to get through to the patient, DBT, meaning dialectical behavior therapy. If you have two patients who are talking to each other about their problem, interpersonal therapy. If empathize the patient, what is the name of the therapy? Empathize the patient. Support therapy. Supportive therapy. Easy or not easy? Easy. Dialectical therapy. Dialectical therapy is, let's say you dialectical behavioral therapy. Okay, so for Dr. Ahmed, dialectical behavioral therapy. What is dialectical behavioral therapy? First of all, dialectical behavioral therapy is the therapy in which you use your conversation and communication skills to talk to the patient, to try to understand what the patient's problem is, and try to see how the world perceives the patient and how the patient perceives the world. Okay, if you can try to get through to the patient with your conversation and communication skills, this type of therapy is known as dialectical behavioral therapy. Am I clear? Okay. Okay, next one. Next one is I want to talk about I want to talk about some psychiatric illness and what are the drugs that we use for those illness. This is very easy to understand. Okay, I'm pretty sure a lot of you guys have know the drug. Okay, so I'm going to ask you fast questions and I need some fast answers. Okay, if you have a patient with ADHD, what is the preferred drug that you will use? Okay, amphetamines and amphetamines and what else? Do you guys remember I talked about methylphenidate? Methylphenidate in my U. Okay, good. If you have a patient with alcoholic withdrawal, what are you going to use? If you have a patient with alcoholic withdrawal, what are you going to use? Benzodiazepine. Very good. If you have a patient with bipolar disorder, what are you going to use? Bipolar disorder, lithium. And if not lithium, then what else? We talked about another anti-seizure medication. Do you guys remember that? Valproate. Okay, valproate. Okay. What can we use for bulimia nervosa? We talked about this. Bulimia nervosa. Very good. SSRI. What can we use for depression? Depression. What can we use for depression? TCA, and SSRI. Okay. What can we use for generalized anxiety disorder? Generalized anxiety. Very good. What can we use for obsessive compulsive disorder? Very good. Okay. SSRI, we can also use NRI and TCA, but SSRI is number one. Next one, panic disorder. What can we use in panic disorder? SSRI. Okay. Then schizophrenia. Can we use SSRI and schizophrenia? Please don't say yes. Okay. What will happen if you use SSRI in a patient with schizophrenia? Increase, will increase the mania or decrease mania? Okay. Increase. What we use? Do we use typical antipsychotics or atypical antipsychotics? Atypical. Why use typical and not typical? Is there ability that typical antipsychotics can cause extrapyramidal sign symptoms? Yes or no? Okay. How about a patient with social anxiety disorder? Can we use SSRI in social anxiety disorder? Yes. Can we use SSRI in Tourette syndrome? Tourette syndrome. Can we use SSRI in Tourette syndrome? If we use SSRI in Tourette syndrome, will there be increased serotonin or decreased serotonin for people in Tourette syndrome? Increased serotonin. In Tourette syndrome, will this increase your tics or decrease your tics? This increase. So having said that, now um, Is the voice better or is the voice better? Okay. Okay. Let me come back. Okay, so can you guys hear my voice now? Is the voice better? Can you guys hear my voice? Is the voice better? Okay. So first of all, my apologies once again. I don't know why this keeps on happening on Zoom. Zoom crashes at times. Okay, and this is because of the increased storage that we use. Give me one moment to get back on track, please. Give me one moment to get back on track. Okay, so let's begin. Okay, so where were we? We were talking about Tourette syndrome. Okay, so what would happen if you gave SSRI to a patient in Tourette syndrome? Will this increase the serotonin or decrease the serotonin? Fast answers, please. We don't have a lot of time today. Will this increase the serotonin in Tourette syndrome or decrease the serotonin in Tourette syndrome? Increase the serotonin. If you have increased serotonin in Tourette syndrome, will this cause exacerbation of that vocal and the verbal and the motor tics? Yes or no? Yes. So can we use SSRI in Tourette syndrome? No. Okay, so what do we have to use for Tourette syndrome? What can we use for Tourette syndrome? Antipsychotics. Okay, antipsychotics. Very good. So for Tourette syndrome, what we will do is we will use antipsychotics. Okay. Next one. Next one is okay. Next one is we. I want to talk about. Okay, let me share the screen with you guys so that I can talk about the next group of drugs. The next group of drugs that I want to talk to you about. Okay, the next group of drugs that I want to talk to you about is CNS is CNS stimulants. Okay, CNS stimulants. Okay, so what are the CNS stimulants that we have? We have amphetamines, dextromethorphan, lisdexamphetamine, methamphetamine. Am I correct? So what happens is these stimulants, how do they act? First of all, how do they act is, let's say that this is the presynaptic cleft. Okay, let's say that this is the presynaptic cleft and this is the postsynaptic cleft. This is the postsynaptic neurotransmitter. This is the synapse, and this is the presynaptic neurotransmitter. Okay. So first of all, over here you have these reuptake channels. Okay. This CNS stimulants, what they will do is, first of all, there's two ways that they can act. First of all, they can increase the catecholamines. Okay, they can increase the catecholamines in the synapse. Number one, by themselves, by increasing or by promoting the release of the catecholamines. And number two is they will block the reuptake inhibitors. They will block the reuptake inhibitors. So there's two ways that the CNS stimulants can work. First of all, increase the catecholamine in the synapses, and then over here. So if this is how they work, okay, so if this is how they work, we know that we can use them in, where can we use them in, so like what is the clinical use of amphetamines? We just talked about this. What is the clinical use of amphetamines? Fast answers: ADHD. Okay, can we also use amphetamines in narcolepsy? Yes, so ADHD, narcolepsy. Okay, ADHD and narcolepsy. And when you have amphetamines, do you have increased appetite or decreased appetite? Fast answers: decreased appetite. So can we use them in binge eating disorders? Can we use them for binge eating disorders? Okay. So what are the three clinical uses of CNS stimulants? Three clinical uses of CNS stimulants. Fast answers, please. Fast answers. Three clinical use of CNS stimulants: binge eating disorder, narcolepsy, and ADHD. Very good. Very, very good. What are the adverse effects? Adverse effects of narcolepsy. If you have increased amount of catecholamine, will you have anxiety and agitation? Will you have increased anxiety and agitation? Good. Will you have tachycardia, hypertension? Yes. Will you get weight loss because your appetite will decrease? Yes. Okay. So these are all the adverse effects of CNS stimulants. Okay. These are all the adverse effects of CNS stimulants. And having said that, okay, and having said that, we have finished CNS stimulants. Okay. We have finished CNS stimulants. If you guys could read the text of the CNS stimulants, you guys can see that we have talked about all the highly important things about CNS stimulants. Have you guys understood how the stimulants work? Where can we use them? What are the adverse effects? Okay. Okay, good. So these are the CNS stimulants. Okay. Now let's move on to antipsychotics. Okay. Now let's move on to antipsychotics. Okay. Okay, good. So antipsychotics, how many types of antipsychotics do we have? Fast answers. How many types of antipsychotics do we have? Two types. Okay. What are the types of antipsychotics? Typical and atypical. Very good. First, we will talk about the typical antipsychotics. Okay. How do the typical antipsychotics work? Okay. Typical antipsychotics. Before we do that, do you guys remember what is the secondary messenger system of dopamine? Second messenger system. What is the second messenger system of dopamine? We talked about them in endocrinology. CAMP, cyclic AMP. Very good. Okay, cyclic AMP. Okay. Okay. So how does the typical antipsychotic work? Typical antipsychotics, are they dopamine agonists or antagonists? Antagonists. Very good. So they're dopamine antagonists. Now, in which pathway do we get the positive symptoms, and in which pathway do we get the negative symptoms? We talked about this before. Which pathway do we get the positive symptoms? And very good. If we block the dopamine in these pathway, if we block the dopamine in the mesolimbic and mesocortical pathways, this help in decreasing the psychosis? Yes or no? Yes. Okay. So this will help in decreasing the psychosis, because psychosis happens because of the positive and negative symptoms. Okay. Okay. So can we use typical antipsychotics in schizophrenia? Fast answers. Schizophrenia. Okay, typical antipsychotics can be used to treat schizophrenia, bipolar, delirium, Tourette syndrome. Okay, but do we have to use them with caution? Yes. Okay, good. Okay, so we have to use them with caution. Okay, but do we use a lot of typical antipsychotics for schizophrenia, bipolar, Tourette syndrome nowadays? Yes or no? No, we do not use a lot of typical antipsychotics. They were used previously. They were first generation antipsychotics, so they were used previously. Okay, but it can be used. It can be used, but we do not use them. Okay, we have to talk about some highly potent typical antipsychotics. Okay, highly potent typical antipsychotics. This is very important for you world. Very important for you world. Okay, and the mnemonic that I want to use is hal. Hal. Have you guys seen the Green Lantern? Have you guys seen the Green Lantern, the movie by Ryan Reynolds? Anyone? No one? Okay. Do you guys know the comical character Green Lantern? Green Lantern. Okay. Doctor, you see a lot of movies. Yes, I see a lot of movies. Try to learn from it. Okay. That's my best pastime. Okay. I try to see a lot of movies, TV shows with my wife. Okay. So that's that. So the thing is, okay, first of all, let me show you a picture of Hal. Let me show you a picture of Green Lantern. Have you ever seen this character, Green Lantern? No? Okay. Do you think that this guy can fly? Do you guys think, even if you have not seen him, do you think that this guy over here can fly? Yes or no? Because he's a superhero. It looks like he can fly, right? So the name of this guy is Hal Jordan. Okay, the name of this guy is Hal Jordan. Okay, and the highly potent drugs are tries Hal tries to fly high. Okay, Hal tries to fly high. Okay, for Hal we have haloperidol. For try we have trifluoperazine. For fly, we have flufenazine, and high for highly potent. Okay, high for highly potent. So these are the three drugs that are highly potent antipsychotic. Haloperidol, trifluoperazine, and flufenazine. Okay, are we clear? Are we clear? Yes or no? Have you guys written down? Okay, I'm pretty sure this mnemonic is taken from first aid. So that's that. Okay, this mnemonic is taken from first aid. So pretty sure you guys will find this in first aid. Next one. Next one is low potent. Okay, next one is low potent drugs. Low potent drugs. Low potent drugs. The mnemonic that we will use is cheating, cheating thieves. Cheating thieves are low. Okay, cheating thieves are low. For cheating thieves, we have chlorpromazine, then thioridazone. So two drugs, chlorpromazine and thioridazone, and they are low potent. Okay, it's important that you understand which are the highly potent drugs and which are the low potent drugs. Why are they important? They're important because will ask you questions regarding the potency of the drugs, because the more potent the drugs are, the more easily they can cause the extrapyramidal sign symptoms. Okay, so that's that. Okay, so highly potent and low potent. That's that. Okay, along with this, typical antipsychotics, another problem. They have another big problem. Okay, so what we're going to do is we're going to talk about the adverse effects of the typical antipsychotics. Okay, so the typical antipsychotics, they have a lot of adverse effects. First of all, the typical antipsychotics, they are very much lipid soluble. Okay, they are very easily soluble in fat. So if they are soluble in fat, can they stay in the body for a long period of time? Yes or no? Fast answers. Yes. So they are, since they are fat soluble, they can stay in the body for a long period of time. Next one is, if you block dopamine, will prolactin increase? Yes or no? Right, very good. If prolactin increase, can the patient get galactorrhea, oligomenorrhea, and gynecomastia? Yes. Okay, good. So that's another problem. Okay. Along with this is, if the patients are on typical antipsychotics, okay, if the patients are on typical antipsychotics, are antipsychotics known to cause weight gain and hyperglycemia? Yes. Okay. They can cause weight gain and hyperglycemia. Along with this, typical antipsychotics are known to be antimuscarinic. Okay. They are known to be antimuscarinic. Okay. They're also known to be antihistaminic. Okay. If the patient has anti-muscarinic effects, will the patient have dry mouth, constipation, urinary retention, decreased bowel movement? Yes. Okay, good. So you guys know the anti-muscarinic side effects. If the patient has antihistaminic side effect, will the patients get sedation? Yes or no? Okay. Along with this, they also, what they do is, along with this, what they do is they also block the alpha one. Okay. Along with this, they also block alpha one. So they are anti-muscarinic, antihistaminic. They block the alpha 1. Okay. If you block alpha 1, will this cause peripheral vasodilation or vasoconstriction? Vasodilation. So if you stand up after you have been lying down, will there be peripheral pulling of the blood? Will there be peripheral pulling of the blood? Yes. If there's peripheral pulling of the blood, can the patients get orthostatic hypotension? Hypertension, orthostatic hypertension. Very good. So alpha 1 blockade can cause orthostatic hypertension. Along with this, antipsychotics are known to cause, they are known to cause QT prolongation. Okay, they are known to cause QT prolongation. Okay, right. Another one is, do you guys remember we also talked about the fact that antipsychotics can cause another condition called neuroleptic malignant syndrome? Yes or no? Yes, so they can also they can also cause neuroleptic malignant syndrome. Okay, neuroleptic malignant syndrome. Okay, and another one is, they can also cause extrapyramidal sign symptoms. Okay, that is the most important adverse effect. The most important adverse effect is extrapyramidal sign symptoms. Now let's talk a little bit more about the extrapyramidal sign symptoms. If we have a patient who, after having the typical antipsychotic, they have painful muscle spasm. Well, what is the name of this what is the name of this extrapyramidal sign symptom? Acute dystonia. Okay, Dr. Ahmed, I'm going to answer your question, but just please, let's finish the discussion first. Keep the questions. When I ask you guys, if you guys have any questions, please ask me the questions then. Okay, let me just finish the discussion and we will come back to your question. Thank you. Okay, next one is, if you have a patient who is, after having the antipsychotics, if the patients get restless, if the patients get restlessness, what is the name of this extrapyramidal sign symptoms? What is the name of this extrapyramidal sign symptom? Akathisia. Very good. Akathisia. Very good. If the patients have tremor, rigidity, bradykinesia, what is the name of this one? Parkinsonism. Very good. Okay. If we have a patient with acute dystonia, do you remember we talked about a very rich patient yesterday who came to the hospital with acute dystonia? He came in a car, Mercedes Benz. Okay. What do we need to treat a patient with acute dystonia? Benztropine. Okay, benztropine. If we have a patient with restlessness, okay, the patient is restless. Can we give them beta blockers? Can we give them beta blockers? Restless patients, do you remember we can give? Right, very good. Okay, so we can give them beta blockers because this will help decrease the sympathetic activity of the body. Okay, next one is if you have a patient with Parkinsonism, can we give them uh, bromocriptine, selegiline, residuline, levodopa, carbidopa, amantadine? Okay, very good. Another one is if we have a patient with chorea, especially orofacial chorea, okay, facial twitching, okay. Do you guys know the name of this type of extrapyramidal sign symptom? Extrapyramidal sign. Have you guys heard of this extrapyramidal sign called tardive dyskinesia? Tardive dyskinesia. Tardive dyskinesia is orofacial chorea. Okay, orofacial chorea. Okay, so how many types of extrapyramidal sign symptoms did we talk about? We talked about, first of all, we talked about acute dystonia. Okay, acute dystonia. Then we talked about akathisia. Then we talked about Parkinsonism. Then we talked about tardive dyskinesia. Then we talked about tardive dyskinesia. Okay, and now what's happening is for the first hours to days, you will have acute dystonia. After that, days to month, okay, days to month, you can have akathisia and Parkinsonism. And then eventually from months to years, you can get tardive dyskinesia. So this is the prolongation. So first of all, if I ask you what is the number one, what is the primary extrapyramidal sign symptoms you can see in a patient, your answer should be acute dystonia. Okay. If I tell you what extrapyramidal sign symptoms you can see in a patient between months to years, akathisia. If I tell you what is the experimental sign you can see after years, after 2 or 3 years, 2 or 3 years, extrapyramidal sign symptom, tardive dyskinesia. Okay, okay, good. Now, if we have a patient who is having these types of problems, is it important? Tardive dyskinesia, what does it mean? Okay, okay, we are going to explain all the questions. Just let me finish the discussion. 1 second. If we have a patient with tardive dyskinesia, can we stop the typical antipsychotic and start with the atypical antipsychotics? Yes or no? Yes. Okay. So that is the best mode of treatment. Okay. For people on extrapyramidal sign symptoms, stop the typical antipsychotics and start the atypical antipsychotics. Okay. Now, since I'm done with the discussion on typical antipsychotics, now let me hear your questions and I will answer them one by one. Number one question. Do we have any questions? If we have questions right now, now is the time to ask. Okay. I apologize for not being able to answer the question during the discussion because I needed to have a smoother track of thought. Okay, thank you. Okay, 1 second, Dr. Karbasi, let me just answer the first question first. Pimozid, is it high or low? Pimozid. Pimozid is high or low. Pimozid is definitely not high, okay? But then again, it's not even that low. It's of the potency of Pimozid, okay? The potency of Pimozid is uh, right somewhere in the middle, to be honest. The first day does not really specify it, but it is more on the higher side. Okay, it is more higher than chlorpromazine. It is a more higher than chlorpromazine, but it is less higher than flufenazine, trifluoperazine, and haloperidol. Okay, so Pemazid is higher than the low potency, but lower than the higher potency. Am I clear? Somewhere in the middle. Are we clear, Dr. Ahmed? Do you have any question? Do you have any more question? No more question, I guess. Dr. Karbasi, what is your question, please? Can you please use the chat box for now? Dr. Karbasi, what is your question? Mm-hmm. Between behavioral therapy and DBT. Difference between cognitive behavioral therapy and dialectical. Cognitive behavioral therapy will teach you how to identify the stress points in your life so that you can stop drinking alcohol and use drugs. That's cognitive behavioral therapy. So the main focus is identification of stressing point. Dialectical behavioral therapy is you use your conversation skills to change someone's behavior and reaction. Are we clear? Are we clear? Dr. Garbasi, are we clear? Difference between behavioral and dialectical. Behavioral therapy is used. Therapy is basically used. Okay, first and foremost, where do we use behavioral therapy? Where do we use behavioral therapy? This question goes to everyone. Phobias, they're good, very good. Okay, so if we use behavioral therapy to expose the patient of what they are afraid of, can this change their behavior? Yes or no? Can this change their behavior? Yes. So this type of therapy to change behavior is known as behavioral therapy. Okay. Any more questions before we move forward? Okay, we don't have a lot of time. Any more question? What is the number one antipsychotic drugs used for schizophrenia? Atypical antipsychotics are used for schizophrenia. Okay. Atypical antipsychotics are used for schizophrenia. We can use we can use clozap we can use clozapine, olanzapine. Okay, but first of all, clozapine is not used until and unless the treatment is resistant. So first of all, we use drugs such as olanzapine, quetiapine. Okay, and then when the sign symptoms of schizophrenia are not working with drugs such as olanzapine, quetiapine, risperidone, okay, ziprasidone, then for treatment-resistant schizophrenia, we will use clozapine. Okay, the thing is, we have not discussed about this right now. We would have discussed about this in the future if you would have seen. Okay, so do not worry. We will begin atypical antipsychotics and we will discuss about the treatment of schizophrenia. Okay, hope that answers your question. Does anyone have any other question before we move forward? Does anyone have any other question before we move forward? Okay, so hopefully no more questions. Now, have you guys understood typical antipsychotics? Fast answers, please. Have you guys understood typical antipsychotics? Okay, let me ask you very quick. What are the adverse effects of typical antipsychotics? How many systems do they affect? Fast answers. I need some fast answers for this. Okay. What are the adverse effects of typical antipsychotics? Okay. First of all, they can address the extrapyramidal, antimuscarinic, then antihistaminic, okay, alpha 1 blockers, okay, extrapyramidal symptoms, right? Very good. So do you guys realize that you guys can have patients with so many sign symptoms if the patient is on typical antipsychotics, QT prolongation? Okay. Okay, good. Next one. Okay, there are two more drugs that I want to talk to you about of typical antipsychotic. Two more drugs. First of all, there are some changes in the eye. Okay, okay, changes in the eye. What happens with typical antipsychotics when you have? So there are two drugs. First of all, chlorpromazine. Okay, chlorpromazine. This drug, chlorpromazine, C for C. So chlorpromazine can cause corneal deposits. Okay. Another one is thioridazone. Thioridazone. Thioridazone can cause retinal deposits. Okay. T. T for thioridazone, T for retinal deposits. Okay. Am I clear? Am I clear about the ophthalmological deposits? Yes. Okay. Please don't ask me why there are deposits, because the mechanism is not clear. The mechanism is not unknown. I mean, it's not known. Okay. So there could be corneal deposits in chlorpromazine and retinal deposits in thioridazone. Okay. Next one. Next one. The next group of drugs. I love these group of drugs for the fact that the mechanism of action of these group of drugs are absolutely unknown. Okay. When you study a drug with an unknown mechanism of action, okay, that is an advantage, because you don't have to spend extra time understanding what's happening over here. Okay. But having said that, these drugs, okay, these drugs which I want to talk about, that is atypical antipsychotics. These drugs, their first mechanism of action is they're not known, it's unknown. Okay. But they're still D2 blockers. Okay. They are D2 blockers, and along with D2, what they also do is they also block 5-HT2. Okay. So they block D2 and they block 5-HT2. So that's that. Okay, so these antipsychotics, what they do is they have less extrapyramidal sign symptoms than the typical antipsychotics. Okay, and the thing is, their effect on alpha 1 and H1 receptors are not that much. So their patients do not get a lot of orthostatic hypotension and sedation. Okay, so that's that. Clinical use. Can we use these drugs for psychotic, psychiatric illness such as schizophrenia, OCD, Tourette syndrome, bipolar disease? Yes or no? Yes, we can use these drugs. So that's what we do. So what are these drugs? These drugs are first of all, these drugs are up uppins. Uppins. Okay, what do I mean by uppins? Uppins are clozapine, olanzapine, then quetiapine. Okay, everything with uppin. Okay, then what else? Then we have peridones. Okay, what are the peridones? Risperidone, then ziprasidone. Okay, ziprasidone. Okay, are you guys familiar with these drugs? I'm pretty sure you guys are, because I've heard you guys say out these names before when I was asking you guys during UWorld notes, and you guys are very, very familiar with this. Have you guys studied these drugs in details in your bachelor's or in your previous medical degree? Yes, of course you did. Okay, because these are very famous drugs used all over the world. That's what it is. Okay. Now the drug that I want to talk to you about, okay, the drug that I want to talk to you about in details is, if you start to treat the treatment of schizophrenia with drugs such as risperidone and olanzapine and quetiapine, and if it doesn't work, then that type of schizophrenia is known as treatment-resistant schizophrenic disorder. Treatment-resistant schizophrenic disorder, and the drug that we can use, that we have to use for treatment-resistant schizophrenic disorder is clozapine. Okay, clozapine. Okay, and now my question is, if that's the case, is it a good choice to start the treatment of schizophrenia with clozapine? Is it a good choice? No, because we have to keep it for later, just in case the first one doesn't work. Then we can use it for later. Okay. Having said that, clozapine has some adverse effects. Clozapine has some serious adverse effect. The number one adverse effect of clozapine is decrease in count of white blood cell. Okay, agranulocytosis. Okay, And another one, which clozapine does, is it decreases the seizure threshold level, so patients can get seizure. Okay, so patients can get seizures. So these are the two adverse effects of clozapine. Okay, another one, another one is clozapine can also cause obesity. Okay, clozapine can also cause obesity. So these are the three things. So first and foremost, this is the number one, agranulocytosis. They can cause seizure and they can cause obesity. Okay. Okay. Having said that, there is another drug that has another major adverse effect. Okay. The name of that drug is risperidone. Okay. Risperidone is risky. It's a very risky drug. Why? Because risperidone can cause hyperprolactinemia. Hyperprolactinemia. Okay, not that high yield, not as much as high yield as clozapine. Clozapine causing agranulocytosis is more important. Okay, this you will get a lot of question from the fact that clozapine causes agranulocytosis. A lot of questions. That's that. Okay, so having said that, we are done with clozapine and atypical antipsychotics. Do we have any questions regarding atypical antipsychotics? Do we have any questions regarding atypical antipsychotics? Yes or no? Okay, good. If we do not have any questions, then we can move forward. Okay, the next group of drugs that I want to talk to you about is lithium. Okay, what is the number one use of lithium? Number one use of lithium. Where do we use lithium? Bipolar disorder. Very good. Okay. Okay. Lithium is also one of my favorite drugs. Why is lithium one of my favorite drugs? Fast answers. Why is lithium very good? Okay. No mechanism of action. Mechanism of action is absolutely unknown, but there is a but. The but is it's possibly related to inhibition of phosphatidyl inositol cascade, inhibition of PIC. Okay, but it's still not clear that it could be related to the inhibition of phosphatidyl inositol cascade. Okay, have you guys know what I'm talking about, right? You guys have heard about the phosphatidyl inositol triphosphate pathway, right? How it forms into inositol triphosphate and triacylglycerol, right? IP3 and DAG, right? Good. So it is involved with the inhibition of phosphatidyl inositol cascade, but it's still not sure. But if you ever receive any question, which I highly doubt you will, then try to remember that they inhibit the pathway of phosphatidyl inositol cascade. Clinical use they are used for mood stabilizers for bipolar disease. That's what you have said, and that's what's important. Okay, they can also be used to treat manic episodes. Okay, another thing is adverse effects of lithium are very important. What are the adverse effects? And you will be highly tested on lithium adverse effect. First of all, do you remember how I taught you guys on how to treat a lithium toxicity? How do you treat a lithium toxicity? How do you treat a lithium toxicity? Stop the treatment and then aggressive hydration and hemodialysis. Okay, hemodialysis. Okay, very good. Okay, now what are the adverse effects of lithium? First of all, lithium, the word lithium, L and T in lithium, L and T is for low thyroid, meaning it can cause hypothyroidism. Okay, then H for lithium in the heart in babies can cause atrialization of the right ventricle, known as Epstein's anomaly. Okay, we have talked about this, Epstein's anomaly. I in lithium can cause nephrogenic diabetes insipidus. M can cause UM. Okay, U and M can cause unwanted movement or extrapyramidal sign symptoms, unwanted movement. Okay. Okay, that's that. Okay, so right now the thing is, um, do you guys remember that I told you that the reason for lithium toxicity is thiazide diuretics. If you use thiazide diuretics, yes or no? Do you guys remember that? That if you patients on thiazide diuretics, they can cause lithium toxicity. Okay. Okay, good. So right. So and also drugs that decrease the GFR. That's also the drugs. Okay. So that's that. Lithium on the other hand, do you guys have any idea on which part of the kidney is lithium absorbed from? Which part of the kidney is lithium absorbed from? Proximal convoluted tubule. Very good. Okay, so keep that in mind. Proximal convoluted tubule. Okay. Okay, very good. Okay. So we are done with lithium. Okay. So do you guys realize what we are doing with the drugs and first aid? Okay. What we are doing with the drugs and first aid is I am trying to make you guys understand the names, important adverse effects, mechanism of action, and on the whiteboard instead of looking at the text in first aid. Because when it comes to drugs, okay, if you have to understand way more than you have to memorize or review. Okay. So that's that. So that's what we are trying to do. Okay. So naming the side effect and treatment. Okay, so we are asking you the side effect. Since you guys already know the side effect, the important ones we will name it out, do not worry, for the purpose of your US7 of the U world, and for the ones you guys already know. So that's that. Okay. Next one is, after we are done reading this, I will give you guys 5 to 10 minutes in which you guys can read the whole text, and you guys will realize that we have discussed every single details in first aid. We have not left out one single word. Okay. So having trust in us, let's move forward. Is everyone ready? We will start with the next group of drugs. Okay. Is this lecture helping you guys out with the drugs, or is it confusing you more? Is it easier than reading the book? Okay. 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 All right. Having said that, let's move forward. Okay. Next one. Next one is next drug I want to talk about is next one. The next drug I want to talk to you guys about is, one second. Okay. Okay. Next drug. Okay. Have you guys ever been on a bus stand waiting for a bus? It's a very stupid question. I'm sure everyone has, right? We have all waited on the bus stand waiting for the bus to come. If you have to go back home and the bus is late, do you get anxious or not anxious? Yes. It's a very anxious type of a situation. You get severe anxiety, right? So so we what's going on over here is we're teaching a mnemonic. We get anxious. We get anxious if the bus does not arrive. Anxious and bus. Okay, what's going on over here? The mnemonic is used for the fact that there's a drug called buspirone. Okay, buspirone or buspirone. This drug is very famous for its clinical use. That is, it's used very famously for generalized anxiety disorder. Okay, and this drug, buspirone, which can cause generalized anxiety disorder, the mechanism of action of this drug is this is a okay, this is a 5-HT 5-HT1. It's a 5-HT1 agonist or stimulator. Okay. We get anxious if the buzz does not arrive. Anxious is for anxiety, buzz for buspirone, and buspirone, if you see that they have the word one already in the name, buspirone. Okay. So they are used to stimulate 5-HT1 receptor. Are we clear about buspirone? Okay. This drug has only one downside. The downside of buspirone is it takes around 1 to 2 weeks. It takes around 1 to 2 weeks to start taking its action. It takes a long time. So if you have a patient who has generalized anxiety disorder, if they are having buspirone, if after using 1 week they come to you and tell you that the drug that you prescribed for me is not working, I'm still anxious. Do you tell the patient to discontinue the drug or to keep on having the drug because drug the drug's onset of action is after 1 to 2 weeks? Yes, the patient has to keep on continuing to have the drug. Is this a UL question? Is this a UL question? Yes. Okay. So you guys do a UL question to understand that this is a UL question. Okay. So UL has questions where they will ask you whether you should stop a patient from having buspirone. Okay. So that's that. Okay. The next group of drugs that we want to talk about is antidepressants. Before we start talking about antidepressants, since we have not taken a long break, it's already been close to around 2 to 3 hours. Do you guys want to take a 10 to 15 minute break before we move on because we're almost close to the end? Okay, it's 11:45. So if we take a 10-minute break, then we can come back at 12 perfectly, and we can begin the last parts. Okay. Okay, thank you. That is good. So just get refreshed. We are very close to finishing the antipsychotics. I mean the psychiatric drugs. Okay, so we will come back in 10 minutes. Okay, so it's exactly after 15 minutes that we are back. Is everyone back from their break? Okay. Um, okay, so once again, let me thank you all for doing this lecture on a holiday. I'm not sure if Thanksgiving is a big thing in your respective country, but is today a holiday over there in your respective countries? Okay, good. Okay, so okay, but still, I just want to thank you for being here with us for the lectures. Okay, so that's that. Okay, and also for the time and attention that you are putting, and we really appreciate the effort. Okay. Okay. So before we begin, can we ask for 1 second how many students we have from all the different countries? Just the name of the countries which you guys are from. I know from where you guys are, just to see the diversity of the students over here. Okay, so we have Pakistan, USA, Sudan. Okay, another student from Sudan, Germany, Ecuador, Eritrea. Okay, okay, good. Okay, Virginia. Okay, Ukraine. Okay. Okay, good. That is very, very good to know. Caribbean islands. Okay, nice. Okay, good. Okay, good. So, having said that, the reason is me and my wife we were thinking of taking a vacation. So, if we come to any one of these places, hope you guys will help us out. Let us know what where the places, which places we can come to go and visit. Okay, if we ever come to Ukraine, Caribbean islands, Sudan. Okay, Pakistan. Maybe you guys can help us out. Let us know which places we should visit, we should not visit. We're big fans of traveling. That's that. And obviously, I will always be here for you all if you guys ever come to New York and you guys need help with your whole process step of assembly from the beginning to the end. Okay, I will be as much of as a help as possible, helping you guys with everything you guys need. Okay. So, having said that, so let's begin. Okay, so let's begin on the second part of our discussion. We are very close on finishing. You want to go to Germany for Oktoberfest. We wanted to go to the Oktoberfest too, but then COVID hit us. So that's that. So, yep, that's it. Okay. So, having said that, okay, so let's begin with today's lecture. We don't want to spend any more, waste any more time. It's already been 10-15 minutes break. Okay, the next discussion that we would begin right now is antidepressants. Okay, so we will start with antidepressants, and I'm pretty sure you guys know what are the antidepressants. First aid is very first aid focuses a lot on SSRI. First of all, what we would do is we will show you how the antidepressants work. Okay, so we have two types of synaptic channels. Okay, we have two types of synaptic channels. Okay, this is the noradrenergic, and then this is the serotonergic. Okay, non-adrenergic and serotonergic, and this is another one that this is the post-synaptic neurotransmitter. This is the post-synaptic neurotransmitter. So what's happening over here is that we have a couple of drugs which are being used. So first of all, let's look at the normal physiology. What happens is you have the neurotransmitter over here, okay, and then they get inside the synaptic vesicle. Okay, they get inside the synaptic vesicle, and then the synaptic vesicle fuses, and then you have the release of the neurotransmitters. Okay, so that's that. And then after that, the neurotransmitters will go and then they will bind to this, and the neurotransmitters can get reuptaken. Okay, the neurotransmitters can get reuptaken. And there's also another type of receptor over here. This receptor is known as alpha 2 receptor. Okay, and alpha 2 receptor is this, will this increase sympathetic or decrease sympathetic activity? Decrease. So, okay, decrease. Okay. So if we have to increase the action of noradrenergic, do we have to block it or stimulate it? Do we have to block it or stimulate it? Block it. If we block the alpha 2 receptor, then this will stop preventing the sympathetic activity. As a result, it will increase the sympathetic activity. And if sympathetic activity increase, then increased amount of norepinephrine could get released. So this has to be blocked in order to work. Okay. Next we have the serotonergic one. Okay, in serotonergic, the serotonin one is 5-hydroxytryptamine, and then in the same way, the 5-hydroxytryptamine will get inside the vesicle, and then the vesicles will fuse, and then they will release the vesicle, and then we have the serotonergic receptors over here. Okay, so first of all, there's just one drug. There's one group of drug which breaks down these neurotransmitters, and that the name of that drug is monoamine oxidase. Okay, the monoamine oxidase. Okay, monoamine oxidase. Okay, so if we want to increase the neurotransmitters, do we inhibit monoamine or stimulate monoamine? Inhibit monoamine. So we have to use monoamine inhibitors. That's number one. Number two is, if we block the reuptake inhibitors, will this increase the serotonin or decrease the serotonin and norepinephrine? If we inhibit, increase serotonin. So as a result, what would happen is, the neurotransmitters would increase. So the serotonin reuptake inhibitors, these are known as SNRI, serotonin norepinephrine, and these ones over here, they're also blocked, and they are known as SSRI, selective serotonin reuptake inhibitors. Okay. Along with this, does TCA also help with TCA? Does tricyclic antidepressant, do they also help in preventing the reuptake? Yes or no? Yes or no? Okay, yes. Good. So they also increase. They also help in TCA. They also help in blocking these receptors. Okay, so TCA, they also help in blocking these receptors. Along with this, can you guys name one drug which works over here that blocks the alpha 2 blocker? Very famous drug, which is used for atypical depression. Very good. The name of the drug is metrazepine. Very good. The name of the drug is metrazepine. Metrazepine is the drug which blocks the alpha 2. So metrazepine is blocking the alpha 2, and that's that. So how many drugs did we come up with? We came up with monoamine oxidase inhibitors. We came up with SSRI. Then we came up with SNRI. Okay, we learned about the mechanism of actions, TCA, and we learned about metrazepine. Are we clear about the mechanism of actions of all these drugs? Yes or no? Repeat TCA, please. TCA, what TCA does, okay. TCA, what this does is TCA prevents the reuptake of serotonin and norepinephrine like SSRI and SNRI. Are we clear? It's a reuptake inhibitor. Okay, tricyclic antidepressant. Okay, so having said that, let's start. Okay, let's start with the first group of drugs. Let's start with the first group of drugs. The first one that we want to talk about is SSRI. SSRI meaning selective serotonin reuptake inhibitor. Selective serotonin reuptake inhibitor. Okay, SSRI. And can you guys give me some example of the names of SSRI which we know? Examples of drugs within of SSRI: fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, escitalopram. Are we correct? Are we clear? Okay, good. What is the mechanism of action of SSRI? Can I get some fast answers, please? What is the mechanism of action? Reuptake. Very good. Can we use them in depression, generalized anxiety disorder, panic disorder, OCD, bulimia, all these problems. Yes, very good. So we have understood the clinical uses. Okay. Along with this, another high yield clinical use is another high yield clinical use, along with depression, generalized anxiety, OCD, bulimia. It can be also used for PTSD, and SSRI are also used for premature ejaculations. Okay, premature ejaculations. They're also used for premature ejaculation. Do you have a mnemonic for the drugs? The mnemonic for the drugs, we do not have a mnemonic for the drugs, but the thing is, SSRI are very easy to remember, right? Because fluoxetine, paroxetine, and sertraline are very famous drugs. Okay, so if you have to get question, you will get question regarding from the name fluoxetine, fluvoxamine, paroxetine, every drug ending in etin, except citalopram and escitalopram and sertraline. Okay. Okay. So okay. Next one is if next one is onset of action. Okay. Onset of action. Always remember that if a patient starts on SSRI, what is the first thing you have to figure out before you prescribe SSRI? What is the first thing that you have to evaluate before you prescribe SSRI? Can I get some fast answers? Fast answers. You have to see if the patient has mania, yes or no. If the patient has mania, yes or no. Because if the patient has mania and you prescribe SSRI, will this increase the mania or decrease the mania? Increase mania. Okay, good. So we have to consider mania. That's number one, which we have to consider. Next one is onset of action. The onset of action for SSRI is usually 4 to 8 weeks. Okay, it takes a long time for SSRI to start its action. So if we have a patient who is on depression and you give them SSRI and they come back after 2 weeks and they tell you the drug is not working, will you ask them to continue the drug or discontinue the drug, continue the drug? How long will you ask them to continue the drug? How long will you ask them to continue the drug? Fast answers, please. For at least 4 to 8 weeks. Okay, a month or at least 4 to 8 weeks. That's what you will do. Okay, adverse effects. Can we talk about the adverse effects of SSRI? Adverse effects of SSRI. Okay, first of all, can SSRI cause serotonin syndrome? Can SSRI cause serotonin syndrome? Yes, we talked about this. SSRI is the number one drug which can cause serotonin syndrome. Along with this, what SSRI can do, SSRIs can also cause sexual dysfunction. Okay, very important. They can cause sexual dysfunction. What are the types of sexual dysfunction they can cause? First of all, they can cause anorgasmia or decrease in libido. That is sexual urges. Okay, decrease libido. So that's what SSRI can do. Okay, are we clear on SSRI? Everything? Have you understood everything? Okay. Having said that, the next group of drugs that we want to go to, okay, having said that, the next group of drugs that we want to go to are SNRI. SNRI, the term SNRI is used for the fact that SNRI means that SNRI is your serotonin norepinephrine reuptake inhibitors. SNRI are serotonin norepinephrine reuptake inhibitors. Do you guys know the names of some high yield SNRIs? High yield SNRI. First of all, okay, first of all, okay, the names are venlafaxine, desvenlafaxine, okay, and another high yield one is milnacipran, and levomilnacipran. So venlafaxine, desvenlafaxine, milnocipran, and levomilnocipran. Okay, so that is high yield. These are high yield drugs for SNRI. Okay, so that's that. And now, if I ask you the mechanism of action, what is the mechanism of action of SNRI? SNRI. What is the mechanism of action of SNRI? Fast answers, please. Can I get some fast answers? SNRI, the name says itself. What is the mechanism of action of SNRI? Inhibits serotonin and norepinephrine reuptake. Very good. So if it inhibits the serotonin and norepinephrine reuptake inhibitor, can we use them for depression, generalized anxiety, disorders? Yes, very good. We can use it for depression and generalized anxiety disorders. Okay. Out of all of this, there are two other things that we have to understand is SNRI can also be used for diabetic neuropathy. Okay. For diabetic neuropathy, SNRI can be used. Okay. Because since they increase the epinephrine, the norepinephrine, they increase the sensitivity of the neurotransmitter to carry out sensations. And we know that diabetic neuropathic patients, they have decreased peripheral sensations, and this helps increases the sensation. So we can use it for diabetic neuropathy. Okay. Another important drug is this drug over here, that is milnocipran and duloxetine. These two drugs, they can be used for fibromyalgia. Okay. Do you guys remember we talked about fibromyalgia? Do you guys remember we talked about fibromyalgia? Where did we talk about fibromyalgia? First of all, what is fibromyalgia? What is fibromyalgia? Good. Where did we talk about fibromyalgia? Musculoskeletal. Very good. Musculoskeletal problem. But do you have any specific organic problem in a patient with fibromyalgia, or is it more psychiatric? Is it more psychiatric? Psychiatric. Okay. So we can use duloxetine and milnacipran for fibromyalgia. Okay. Now, if we have to talk about the adverse effects, if you have a patient with increased amount of norepinephrine, will this increase the patient's blood pressure? Yes or no? Will this increase the patient's blood pressure? Yes. So number one adverse effect is hypertension. Okay, increase in blood pressure. Okay. Next one. Next one is if you have a patient with increased amount of an increased amount of, of serotonin and norepinephrine, can this increase the patient anxiety? I mean, can this increase the patient's agitation and stimulation? Can this increase the patient's agitation and stimulation? Yes, it can. So, increase stimulant effects. Along with this, they can also cause nausea and they can also cause sedation. Okay. Okay. How can they cause sedation if they cause stimulation? If they cause stimulation, how will the patients have sedation? Let's see who can break down this puzzle. How can this they cause sedation? First of all, let me tell you myself. The reason why these drugs they can cause sedation is that the neurotransmitters over here they are reuptake inhibitors. So the neurotransmitters over here, due to negative feedback, there's decreased formation of the neurotransmitter as all there's crashing of the neurotransmitters. The neurotransmitters decrease. There's decreased formation of the neurotransmitters as itself. So the body stops producing the neurotransmitters, serotonin and norepinephrine, and the body crashes and burns. So, right, run out. Exactly. That's exactly what happens. Okay, next one. The next group of drugs that we want to talk about is TCA. Okay, TCA, tricyclic antidepressants. Can you guys name me some high yield tricyclic antidepressants? Amitriptyline, then nortriptyline, imipramine, clomipramine, right? So amitriptyline, then we have nortriptyline, imipramine, clomipramine. These are all the high yield drugs. Okay. What is the mechanism of action of TCA? We have just discussed this. What is the mechanism of action of TCA? Reuptake inhibitors. Very good. They are reuptake inhibitors. Very good. Now let's talk about their adverse effects. They're more important. Adverse effects of TCA. First of all, before we talk about the adverse effects, okay, can we use TCA in depression, OCD? Okay, good. Yes, we can. Okay, we can use them in depression, OCD. Okay, can we all, since they are also preventing norepinephrine reuptake, can we also use them in peripheral neuropathy, diabetic neuropathy? Good. Yes, we can. Okay. Along with this, they are also used for. Do you remember we talked about nocturnal enuresis yesterday? Nocturnal enuresis, and we said that we can use an EDH analog, right, to cause to prevent yes, to prevent bedwetting. Over here, TCA can also be used for nocturnal enuresis. So clinical use out of everything. Also, we can use. Also, TCA is also used for sleep enuresis or bedwetting. Okay. Okay. Next one. Next one is the adverse effects. Adverse effects of TCA. Number one adverse effect of TCA is, first of all, TCA is an alpha 1 blocker. If we have an alpha 1 blocker, what is the problem? What is the presentation? Can I get some fast answers? What is the presentation if we have an alpha 1 blocker? Orthostatic or postural hypertension. Very good. Okay, next one. If TCA is anticholinergic, okay, TCA is anticholinergic. If we have a patient with anticholinergic, what are the signs and symptoms of anticholinergic? Dry mouth, constipation, urinary retention. Okay, dry mouth, constipation, urinary retention. These are the problems. Very good. Okay, can TCA prolong QT interval? Yeah. So another adverse effect is TCA can cause prolongation of QT. TCA can cause QT prolongation. Okay. Next one. Next one is, do you guys remember we talked about the fact that TCA can cause convulsion, coma, and cardiotoxicity? We talked about this yesterday. Yes. So TCA can also cause convulsion, coma, and cardiotoxicity. How will you treat a patient with TCA toxicity? We talked about this in the beginning of today's lecture. How will you treat a patient with TCA toxicity? Fast answers. I need some fast answers. Everyone. Sodium bicarbonate. And can you also do hemodialysis for TCA toxicity? Can you do hemodialysis for TCA toxicity? No. For which toxicity will you do hemodialysis? Very good. Okay. Very good. So looks like you guys already know the drugs. Okay. There is no point in teaching first aid to you guys. You guys know first aid. Am I right? Okay. You have a question. Yes. What is your question, Dr. Hazam? What is your question, please, before we begin monoamine oxidase? Not a lot of difference. There's not a lot of difference in between the mechanism of action of SNRI and TCA. Similar mechanism of action. Are we clear? Okay. Okay, good. Next one. Next one, what we want to talk about is monoamine oxidase inhibitors. Monoamine oxidase inhibitor. Okay, the drugs monoamine oxidase inhibitors, the drugs, the names of the drugs are, what are the names of the drugs? Transcyclamine, phenelazine, isocarboxazid, selagelene. Okay, selagelene. Okay, so monoamine oxidase. Monoamine oxidase. So what we can also do is we can use the word selagelene, phenelazine, isocarboxazid, transcyclamin. Okay, tranylcypromine. Okay, I used to keep on saying transcyclamin. That's a bad habit. Tranylcypromine. Okay, tranylcypromine. Are we clear about the names of the monoamine oxidase inhibitors? Yes or no? Yes or no? Are we clear about the names of monoamine oxidase inhibitors? Okay. First of all, now how does so what is the mechanism of action of monoamine oxidase? Fast answers, please. What is the mechanism of action of monoamine oxidase? Do they increase the breakdown of serotonin or decrease the breakdown of serotonin? Decrease the breakdown. As a result, will there be increased Serotonin, epinephrine, and dopamine. Yes, no? Yes, very good. Okay, so as a result, can we use these drugs for depression? Can we use these drugs for depression? Yes. Especially these drugs are also used for depression, and they're more used for atypical depression. Okay. Atypical depression. Do you guys remember what atypical depression is? Will the patient sleep more or sleep less? Fast answers. Sleep more or sleep less? More. Will they eat more or eat less? More. Everything is more. Okay. So that's that. Okay. That's atypical depression. Okay. Next one is monoamine oxidase. Can they be used? Do you guys remember we used the drug selegiline for Parkinsonism? Yes, good. So they're also used for Parkinsonism disease. So atypical depression and Parkinsonism. Okay, monoamine oxidase. Okay, good, very good. And another one is adverse effects. If we have to talk about adverse effects, can these drugs cause hypertensive crisis and and serotonin syndrome? Because they're easy, norepinephrine and all the other stimulatory neurotransmitters, so they can cause hypertensive crisis, they can cause SSRIs, right? And and there's another thing, okay? We have to stop for there's another thing. We have to we have to wait for 2 weeks. We have to wait for 2 weeks after stopping monoamine oxidase if we have to start SSRI. Why is that? Okay. If we give a patient SSRI with monoamine oxidase, can this cause serotonin syndrome? Yes or no? Okay. Yes. So we have to wait for 2 weeks. Why do we have to wait for 2 weeks? Because 2 weeks is the time needed for the monoamine oxidase to get metabolized. Monoamine oxidase inhibitors, such as selegiline, isocarboxazine, these drugs need 2 weeks to get to get excreted from the body. So after we stop the drug, we have to wait for 2 weeks, because after 2 weeks, monoamine oxidase inhibitors in the body will go away, and then we can successfully start SSRI to prevent serotonin syndrome. Okay. Okay. Are we clear? Okay. Good. Okay. Good. Next one. Next one are atypical antidepressants. We will start talking about atypical antidepressants. So first of all, for atypical depression, what are the drugs that we used? Did we use mitrazepine? Did we use monoamine oxidase? Did we use monoamine oxidase inhibitors? Yes. Okay. So that's that. Okay, good. Now what we will do is now we will start about atypical antidepressant. What are the atypical antidepressant or the new age antidepressant? First of all, we will learn the name. Okay. Okay. First of all, we will learn the name. Okay. And in order for us to learn the name, what we will do is we will learn this one story again. Okay. Do you guys remember the story about our villa? Yes. Yes. Okay. Yes, it's high yield. It's high yield. Okay. So you guys remember the story about the villa. Okay. So do you remember what was happening in front of the villa? We had a vortex storm. We had a vortex storm in front of the villa. Yes. Yes or no? Do you guys remember that? Okay. So we had a vortex storm in front of the villa. And last time we had a bus, right? We had a bus. This time what we have is we have a cycle. Okay. We have a cycle. Okay. And in that cycle, okay, we have three people. How many people do we have on that cycle who's going to the villa through the vortex? Three people. Okay. What are the names of these three people? The first the f- the first guy's name is the first guy's name is Traz. The second girl's name is Mir. Okay. And the last guy's name is Boo. Okay. So three people, Traz, Mir, and Boo. And they are on the cycle. They're going to the villa. There's a vortex. This is the picture for atypical antidepressant. Okay. So this villa will help you remember that this is Vilazolam, vortex for vortioxetine, cycle for varenicline, traz for trazodone, okay, mir for mitrazepine, boo for bupropion. Are we clear? Are we clear on this? Did you guys draw this out? Did you guys draw this out? Again, again, villa for vilazodone, vortex for vortioxetine, cycle for varenicline, traz for trazodone, mir for mitrazepine, boo for bupropion. Are we clear now? Okay. Okay. Did you guys draw this out? Okay. Next time, if anyone asks you about the name of atypical antidepressant, will you tell them very confidently that you know all the names of atypical antidepressants? Okay, good. Okay, very well. Next is the unfortunate news is the unfortunate news is we have to learn a little bit about the mechanisms of all these picture drugs. Okay, and they're not that difficult, but we will obviously master them. The first drug that I want to talk about is bupropion. Okay, bupropion, the guy whose name was Boo. Okay, bupropion. How does it work? First of all, bupropion, what it does is it inhibits norepinephrine and dopamine. Okay, very easy to understand. If you inhibit norepinephrine and dopamine, they can have they are used for they are used for depression. Okay, now do you remember that I told you that SSRI can cause sexual dysfunction? SSRI can cause sexual dysfunction as an adverse effect or no? Okay, so if you have a patient who's complaining of sexual dysfunction after having SSRI, what you will do is you will switch the SSRI and you will start bupropion, because bupropion has a favorable sexual side effect profile. Okay, so it does not have many sexual side effects, so people can use this. Okay, so this is very important for UWorld. This is very important for UWorld that bupropion is used if we cannot use SSRI. Okay, very good. Next one is okay. Next one is metrazepine. Do you remember we talked about the mechanism of metrazepine? What is the mechanism of metrazepine? Fast answers. What is the mechanism of metrazepine? Alpha to antagonist, not agonist, alpha to antagonist. Okay, they will block alpha 2. As a result, will this increase in sympathetic activity or decrease in sympathetic activity? Fast answers. Fast answers. Increase sympathetic activity. If sympathetic activity increases, will there be increase in epinephrine, norepinephrine, and serotonin? Decrease. Yes, that is very good. Okay. Along with this, what they will do is metrazepine. Along with this, metrazepine, what they will do is they will block alpha 2. They will block, okay, they're also known for blocking. They're also known for blocking 5-HT2 and HT3. Okay, HT2 and HT3 blocker, but this is not that high yield. This is the most high yield. I'm just saying this for your knowledge. Another one is they're also histaminic blocker, so they're antihistaminic. Okay, and where do we use metrazepine once again? Where do we use metrazepine? Typical depression. Very good. Okay, good, very good. Another one, another one. Next one. Next one is that guy whose name was Straz. Okay, so that the guy whose name was Straz, the mnemonic Traz. Okay, it's used for the word trazodone. Okay, trazodone. Okay, trazodone. What is the mechanism of action of trazodone? Trazodone, what this does is trazodone, this blocks, okay, this blocks 5-HT2, alpha 1, and H1. Okay, along with this trazodone, what this does is it also inhibits 5-HT reuptake. So as a result, there is increased 5-HT. Okay, and they block 5-HT2, by the way, 5-HT2. If you block 5-HT2, will there be increased serotonin for 5-HT1? Yes or no? Yes. Okay, so that's the reason. Okay, there's a very high yield adverse effect for trazodone. Okay, there's a very high yield adverse effect for trazodone. Trazodone causes this problem known as priapism. What is priapism? Has anyone? I'm sure we have discussed priapism before. What is priapism? Painful erection. Very good. Okay, so it is known to cause priapism, and this is inability of erection is the wrong word. Painful, sustained painful erection is the one. So priapism. Okay, and you world will have questions where they will ask you which drug is causing priapism, and it's this drug called trazodone. Okay, trazodone. Okay, that's that. Okay, so trazodone can cause painful erection. Not very high yield. It's not a very high yield drug. Okay. Another one is, do you guys remember we talked about this drug when we said that you can use this for nicotine cessation? If people want to stop smoking, they can use this drug. What is the name of the drug that we said that people can use if they want to stop smoking? What is the name of the drug people can use? Nope, we did not say buspirone. Said varenicline. Very good. We said varenicline. Okay, we said varenicline. Okay. Okay, so varenicline. So varenicline, how does it work? Varenicline, first of all, varenicline, it's a nicotinic agonist, partial agonist, partial nicotinic agonist, partial nicotinic agonist. Okay, so varenicline is a partial nicotinic agonist. If varenicline uh, is causing partial agonism of the nicotinic receptor, okay, this will prevent your cigarette cravings. Okay, this will prevent your cigarette cravings, and yet this is used for smoking cessation. But there's a very big problem with varenicline. The problem with varenicline is the adverse effect, and the adverse effect is it increases suicidal ideation. Increases suicidal ideation. Are we clear on varenicline? Okay. Are we clear on varenicline? Yes. Okay. Is anyone else? Do we have any questions or problems regarding varenicline? Okay, good. Okay. Before we move on to the drugs, can you tell me the mechanism of action of bupropion very quickly? Bupropion, what is the mechanism of action? Mechanism of action of bupropion. Last answer, please. Norepinephrine and dopamine uptake inhibitor. Metrazepine, what is the mechanism of action of metrazepine? Mechanism of action of metrazepine. Alpha-2 blocker. What is the mechanism of action of trazodone? Trazodone. 5-HT1 or HT2 blocker? 5-HT2 blocker. Very good. What is the mechanism of action of varenicline? Varenicline. What mechanism of action of varenicline? Nicotinic or muscarinic? Negative. Partial, negative. Okay. The last two drugs are vilazodone and vortioxetine. Vortioxetine. These are the last two drugs which we will talk about, which are atypical antidepressants, and both of them have the same mechanism of action. Okay, they have the same mechanism of action, that they are 5-HT1A agonist, and they also decrease reuptake of 5-HT. Okay, they also decrease the reuptake of 5-HT. And their adverse effects are the same as SSRI, more or less, that they cause nausea, sleep disturbance, sexual dysfunction, anticholinergic. So they are not that high yield. Okay. And if we take these drugs with serotonin, selective serotonin reuptake inhibitor, can the patients get serotonin syndrome? Yes or no? Can the patients get serotonin syndrome? Yeah. So the patients can also get serotonin syndrome. And the only thing you have to remember about vilazodone and vortioxetine is that they are HT1A agonist and 5-HT reuptake inhibitors. Are we clear? Okay. Last group of drugs. Okay. The last group of drugs that we will talk about today. After this, we are done with psychiatry for good. Okay. And congratulations for coming to this far. Okay, you guys remember almost close to everything. Okay. Last group of drugs we will talk about is a very easy topic, that is opioid detoxificant. Okay. Okay. First of all, what is the number one drug which we said for use as the drug can be used for detoxification or maintenance therapy? The number one drug, which is a long-acting opioid. Very good. Methadone. Methadone. Okay. After that, we also talked about another opioid, which is a partial opioid agonist. Partial opioid agonist. What is the name of that drug? Which can be used for opioid toxicity and opioid detoxification. Very good. Buprenorphine. Okay. Buprenorphine. Okay. Okay. Next one. Next one is, we talked about opioid antagonists. Am I correct? Opioid antagonist. Yes or no? Out of the opioid antagonists we talked about, what are the name of the opioid antagonists? Naloxone, naltrexone. Out of this, let me write it down. Naloxone. Okay, naloxone and naltrexone. First of all, naloxone, is it short acting or long acting? Naloxone, is this a short acting drug or a long acting? It's a short acting drug. Short acting drug. Okay. So we can give naloxone through IV, IM, and nasal spray, because they are fast acting, and in opioid overdose, acute opioid overdose, we can use nasal spray. If we cannot find a proper vein, or if the patient is agitated, we can give IM. So we will use nasal spray if needed to cause an early onset of action of the opioid antagonist to treat the opioid overdose. Another one is for maintenance for a long period of time. If we have to use opioid antagonist, the long acting drug is naltrexone. Naltrexone. Okay. Naltrexone, this is used, since it's long acting, it's used to prevent relapse. This drug is used to prevent relapse. This is used to treat acute opioid overdose. This is used to prevent relapse. Why? Because the one is short acting and the one is long acting. Are we clear on this? Are we clear on this? Yes or no? Okay, yes. Okay, very good. Yes, we can give naloxone to a patient with heroin toxicity. Okay. Okay, having said that, first of all, let me thank you for finishing psychiatry. And second of all, let me congratulate you for not only reading first aid, but understanding, reviewing, recapitulating, and properly accomplishing and applying the knowledge of psychiatry and first aid to your U world question. Okay, so good job, guys. I believe each and every one of you, okay, each and every one of you, who are the students we have with us today? Every one of the students who are not here today, who are watching the video, you guys too, and students such as Dr. Hassan, Dr. Yusuf, Dr. Khalid Maheshwari, Dr. Ibrahim, Dr. Dalia, Dr. Nikki Ahmed, everyone, Dr. Evelyn, Dr. Yosef, Dr. Adhanom, Dr. Naud, Dr. Yosef, every one of you guys, starting from over here to over here, every one of you guys have the potential to score a really, really, really good mark on your assembly step one, and I can vouch for you guys. Okay. I know you guys will do absolutely really, really well. Okay. So just keep on doing what you're doing. Try to keep your focus on the lectures. And there's another thing. So the thing is, we usually try to read we usually try to read 10 pages of first aid every day, but since we started neurology and since we started neurology and neurology was a very difficult topic, but we finished it not on time, but we finished it with good quality. Yes or no? Did we finish neurology properly? Did we not rush through neurology, because neurology is a subject where you will get around 40% questions in USMLE step one. So we did not rush through neurology. We took our time because quality of the study is important more than the quantity. The same goes for your U world. The quality of your question understanding is important more than the amount of questions you do. So having said that, we will obviously pick up our pace from tomorrow when we study renal. We will try to stick to our 10 pages every day so that we don't fall behind on our 3 month, 3 to 4 month notice on finishing first aid. Okay, so we will not fall behind. That's number one. Number two, another thing that I wanted to talk to you about is we promised to go give you subscriptions of Dr. Najib and Physio by this week. Okay, but the thing is, we have the subscription for Dr. Najib already. The Physio subscription, it's taking us some time to start. Okay, but obviously we will start because we need to have Physio when we start microbiology, and we need to use the picture mnemonics from physio when we study immunodeficiency disorders, when we need the pictures to study physio from physio when we study about lysosomal storage diseases and also glycogen storage diseases. Okay, so we will obviously 100% use physio, that's a given. But as for now, the subscription for Dr. Najib are open. So what I need you guys to do is, I know some of you guys have already sent me emails that you guys want Dr. Najib. And to all the other ones who need Dr. Najib, can you guys please use our Facebook discussion group to let us know so that we can properly make a group of 5 to 10 people to whom we can give the subscription ID and password to, so that you guys have to talk and between yourselves about who will use the subscription at which time, so that it does not coincide with the other person, because we have one subscription. So uh, only one of you use it at one time. Okay, so that's that. Okay, so please let me know in the discussion group about who wants the Dr. Najib lectures. That's number two. Number three is, um, since this is a holiday and it's Thanksgiving over here, since we are done with psychiatry, I was thinking if it was possible to skip out on UWorld notes and questions for today and start from tomorrow, since if needed, what we can do is if needed, what we can do is tomorrow we can use more time. We can start early, finish a bit later. Since tomorrow's Friday, the day after that we have the weekend, so we can finish I mean, we can take a lot of time tomorrow to actually read everything out. Okay, so we can do 10 questions if needed. Okay, or that, and also do a little bit more. You will know. But since we have one or two students who are about to leave, and also because of the fact that it's a holiday, I was thinking that we could end the lecture over here for now. Is that okay with you all? Okay, perfect. Okay. Okay, having said that, who are the new students that we have with us today? New students, please let me know now. Who are the new students who have joined for this week? Okay, not today, for this week. Any new students for whom this is the first or the second lecture? Ahmed, okay. Dr. Mohammed, okay, second lecture. Okay. Okay, so for the new students, we provide 1 to 2 days of free trial lectures. That was for every one of you guys who joined our lectures. We provide 1 to 2 days of free trial lectures. If you want to continue with us in the future, please send us an email so that we can help you clear out your transactions for our subscription. The thing is, tuition USMLE Step One tutorship over here in New York is one of the most expensive tutorship. Tutors over here, they charge around 50 to $100 per hour. Okay. But we created this channel because we wanted to teach students, not for the purpose of earning money. So we keep our compensations too. So we keep our compensations to as low as $1 per hour. So we try to teach 5 hours for 5 days. So it's close to 25 hours per week. So we charge $1 per hour. That is $25 per week. Okay. So hopefully you guys will understand that we need our compensation. And please let us know if there's any way we can help you out with the transactions, or if you guys need extension. But if you fail to receive emails from you, or fail to see clear transactions from your end, we will assume that you guys are not interested in continuing the lectures, and we will fail to send you the Zoom URL links for our lectures. So please let us know how we can help, and please send us an email to complete the transactions. Having said that, does anyone have any other question regarding our lectures, USMLE Step 1, regarding the exam? Lecture 19, Dr. Dahlia, I think lecture 19, I think I uploaded it yesterday. I'm going to see it once again, and I'm going to send you the link. Okay. You know what? As a matter of fact, just give me 1 second. Okay. What? As a matter of fact, just give me 1 second. I know you've been asking for this for a long time. Okay. Let me see. Let me see one thing. Let me see one thing. We delete the lectures because we want to create space, okay? Or else we can't upload or record the new ones. Oh, there you go, lecture 19, okay? Lecture 19, okay? Lecture 18 is on the Google Drive. Yes, we will put it all in the, we will put it all in the Google Drive and say, okay? Okay, 1 second. This is the one for lecture 19. For lecture 18, we will send you the link again. Okay, let me see one thing. Okay, let me see. We really do not have enough space for lecture 18 right now as of this moment. If we do not have the proper lecture 18 in the Google Drive, we will upload another one. Do not worry. Okay, we will upload another one. Okay. It's not working. It will work. Just give it some time, since we just recovered the lecture. Since we just recovered the lecture. Yes, just give it some time. It will appear. Since we just recovered the lecture, it will come. Eventually it will come. Okay. So when you see a link, please download the lecture as much as possible. Okay. You have to raise the access to the link. Okay, let's see what's going on over here. Okay, you know what we're gonna do? Straight away, okay, don't use the link. We'll upload it today. We'll upload 18 and 19 today. Okay, we'll upload 18 and 19 on our Google Drive. We have more space right now in the Google Drive. We have more space to accumulate more lectures. So that's not a problem. We will upload it. Okay. Okay. Can you upload the UWorld notes from yesterday? Of course. Of course, we will also upload the UWorlds from yesterday. We will also do it too. But the thing is, the UWorld notes which we did yesterday, it wasn't a lot. We did very less because most of our time was spent on doing psychiatry. So we were thinking of accumulating a bit more lecture and uploading them all together. But eventually, every lecture from UWorld will get uploaded. Okay. Okay, for the new students who want to continue with us and complete your transactions, the email address where you have to send your email to is ferdin.hiley@gmail.com.
I've sent you already, doctor.
Okay, perfect. Thank you so much. Okay, so we will help you through the whole process. And that's that. Okay, if anyone else has any questions, they can ask me right now. If they do not have any questions, then I want to wish everyone a happy holidays and happy Thanksgiving. Hope you guys have a great day today. Thank you so much for doing the lecture and congratulating on perfecting the knowledge and doing the proper review and mastering of all text related to psychiatry and first aid 2020. Okay. Okay. Well, so what is the best thing you guys have to do? Okay. After you guys are done with the lecture, what is the best thing you can do? UWorld. Okay. If you don't apply the knowledge from psychiatry to do UWorld, can we say bye-bye to psychiatry knowledge? Yes. No? Yes. Okay. You gladly say bye psychiatry, and then every knowledge in psychiatry will disappear. Okay. So make sure that we do not say goodbye to the psychiatry knowledge. Hope it stays with us. And in order for that to happen, we have to solve the UWorld question. Okay. So having said that, I will take my leave and hope you guys have a great day. See you guys tomorrow. Send me an email if you guys have any question. Okay. Bye-bye.